straight into the program thereafter. Hannah, over to you.
Thank you all so much for being here today. As Dr. Gabriel said, we understand your time is in high demand right now, and it means a lot that you're all here showing interest in this really important area of policy. So if you don't mind just opening your phone camera and scanning the QR code that I've put up on the screens for a brief 5-minute survey which assesses where you're coming from, whether you're a parliamentarian, a member of civil society, or a parliament support staff, and then tries to gain a bit of a baseline understanding of your knowledge regarding SRHR, so then we can assess whether this session is useful at all in helping you strengthen your understanding, gain some new skills, and whether there's anything we can improve for future events. So I'll just leave you for 5 minutes and we can then proceed from there. Thanks so much.
Do you have it on your screen? Because we can't catch it from this.
Yeah, that one.
Is it close?
That one, I had to zoom in, but I got it eventually.
Oh, yeah. Okay, colleagues. So Hannah, well, I hope, Hannah, you're going to present the data at some point, and then we'll repeat the survey at the end of the program today, just to see whether we've somehow managed to shift the needle with sharing information and having a conversation. Hopefully shift the needle in the right direction. Let me then move on to introducing our member of the Health Portfolio Committee, Honorable Dr. Carl LaRue. Dr. LaRue is a medical doctor by profession and a member of the Portfolio Committee on Health, so also now involved in legislation, policy development, oversight, and public engagement on the area of health care and well-being in the country. Thank you, Dr. LaRue. Thanks.
Thank you very much for having me, and it's great to have everyone here and all protocol observed. When I was asked by the chairperson of the Portfolio Committee to represent the Portfolio Committee today, I need to confess that I wasn't aware that I was going to be required to make a speech. And, you know, as a fairly new member of Parliament, I was elected in 2024, and I am still learning to use the tools that are available to me as an MP to try and understand the broad array of health and other challenges that South Africans face. How to do good and careful oversight, and to hold the executive accountable. I will therefore attempt to marry the prepared comments that the chairperson of the Health Portfolio Committee, Honourable Faith Mutambi, was going to present. And she's obviously been in Parliament a whole lot longer than my 2 years. But I want to marry that with my experience as a doctor who's worked for 25 years in the public sector, and 16 of those were in a small rural district hospital in the deeply rural Eastern Cape. I come here to and look forward to learn from the engagement between the Southern African Development Community Parliamentary Forum, the parliamentary researchers and support staff, civil society organisations and MPs, amongst others. The concept note that the parliamentary research team put together for this day, I think, puts it really accurately, and I quote: "The achievement of sexual and reproductive health relies on the realization of fundamental human rights, hence the term sexual and reproductive health and rights," or for short SRHR. SRHR pertain to decisions regarding marriage, bearing of children, sexuality and sexual experiences, as well as access to information, resources and support that is necessary to make decisions regarding sexual and reproductive health, which are both free and informed. Sexual health and reproductive health and rights is therefore not just a health sector matter. Constitutional rights, gender equality, education, social protection, justice, and the broader socio-economic conditions in which people find themselves are all, and in which people live, are all intertwined. And ensuring these rights therefore requires a whole of society approach and an engagement that is horizontal and not just stuck in a vertical silo as within health. For Parliament, our responsibility goes beyond passing legislation. We must also ensure that the laws and policies are well crafted and that they are actually implementable. Too many times I, as a rural doctor, had to try implement unattainable gold standard policies that undermined our efforts to provide high quality care on the ground, and actually often resulted in worse health outcomes for our patients on the ground. Further, we must ensure that these laws and policies are effectively implemented and that government programs translate into meaningful access to services and to uphold people's rights. Today I'd like to focus on three main areas. Firstly, Parliament's legislative and oversight role in advancing sexual and reproductive health and rights. Secondly, the importance of evidence and meaningful public participation. And thirdly, how civil society and Parliament can work together to strengthen accountability and to improve outcomes. So first of all, Parliament's legislative and oversight role. The Constitution places Parliament at the centre of our democratic system. Parliament makes laws, represents the people, and holds the executive accountable. All three responsibilities are relevant to SRHR. Through legislation, Parliament establishes the legal framework for protecting rights and providing services. But legislation, as we well know, does not guarantee access. This is where effective oversight becomes critical. Parliament must ask whether laws and policies are being implemented effectively and whether public resources are producing the intended outcomes. In the context of sexual and reproductive health and rights, it means asking practical questions. Are services reaching communities? Are healthcare facilities adequately staffed and equipped? Are essential medicines like contraceptives and reproductive health supplies available? Can young people access appropriate and confidential services? Can people in rural and underserved communities access the services that they need? Are vulnerable groups able to exercise their rights without discrimination or unnecessary barriers? Effective oversight requires members of Parliament to be on the ground and not only go into boardrooms while hospital managers present massage statistics to us. We must speak to the doctors, the nurses, the porters, the pharmacists, and patients and their families when we go on oversight. We must check how long patients are waiting in queues, whether the contraceptives are in stock, and whether teenagers are comfortable accessing contraceptive and other care. We must ask about maternal and perinatal mortality rates and understand what it means. We must ask about teenage pregnancy rates, and we need to find out what the procedures are that are followed when statutory rape is suspected. Within the Health Portfolio Committee, sexual and reproductive health and rights related issues arise across a range of areas, including maternal and reproductive health, adolescent and youth health, HIV and sexually transmitted disease services, contraception and family planning, termination of pregnancy services, sexual and gender-based violence, and access to essential medicine and healthcare services. These issues are all interconnected. For example, improving maternal health requires functioning facilities, adequately trained healthcare professionals, appropriate medicines and equipment, and access to care throughout pregnancy and childbirth. Similarly, addressing HIV and STI services requires prevention, testing, treatment, education, and sustained community involvement. Addressing sexual and gender-based violence requires the cooperation between the health sector and other sectors, including the police, justice, social development departments, as we see more and more happening in our Tutuzela care centres. Parliament must therefore consider sexual and reproductive health and rights not only as part of the broader health system, but within the whole of society, and continue to work horizontally across departments and portfolios rather than in silos. We must look beyond the headline performance indicators and ask whether reported improvements are reflected in people's actual experiences and when they access those healthcare services. And as I mentioned earlier, this is best done by being on the ground. As parliamentarians, we can also use tools like the SRHR toolkit that will be presented a bit later today by the parliamentary research team to guide our budgetary, policy and physical oversight. Second area I want to speak about was the importance of evidence. And for us to be able to do effective oversight, we need to be informed by credible evidence. Government departments and public entities provide Parliament with important information through their plans, their budgets, their performance report, and other accountability mechanisms. Sometimes the data for these indicators are well collected and accurate, but my experience of working in a rural hospital has shown me how there are real problems with the data collection using the district health information system. The biggest issues are that a plethora of data points are requested without reliable systems of collecting this data, and secondly, that the flow of this data is unidirectional, from the clinic or the district hospital up to management or to the administrative officers. But that information never gets fed back to the clinicians on the ground so that they can adapt and improve their services. My experience is that sometimes data actually gets made up. I remember sitting in an HIV clinic once while I was seeing patients and the data manager coming around and going, "How many people have we tested for HIV this month?" And the two nurses looked at each other and they were like, "About 150? Yeah, about 150? 150. And back went that data, right? And so that is the reality on the ground. And I think that we need to, that's obviously a problem because it means that the data that we're getting and the information we're getting is not that accurate, and that undermines our plans to try and improve things. It is therefore really important that we get evidence and data from civil society organisations, professional bodies, researchers, healthcare professionals, community organisations, and affected individuals. And this is obviously particularly important and valuable to us here in Parliament. These perspectives can help identify problems and implementation gaps that may not be immediately visible in the administrative data that we are collecting. We therefore need to bring together quantitative and qualitative data, research, government performance information, and the lived experience of patients, including complaint logs at hospitals. This is particularly important when considering the experiences of vulnerable and marginalised groups, including young people, persons with disabilities, and people living in rural and underserved communities. Now, public participation is a defining feature of our constitutional democracy. Parliament cannot effectively represent the people without listening to them regularly. Civil society plays an important role in bringing expertise, research and community knowledge into parliamentary processes. This can take place through written oral submissions, public hearings, stakeholder engagements, and research and advocacy. Public participation should not be treated simply as a procedural requirement or a tick box, but it provides Parliament with an opportunity to understand the potential impact of legislation and policies, consider different perspectives, and identify issues that may otherwise receive inadequate attention. In this regard, civil society strengthens Parliament's ability to make informed decisions and conduct effective oversight. I would like to give you another example of my experience as a rural doctor, and perhaps an example where that communication was not as good as it should have been. And then about 2014, 2015, some of you might know that Implant-On, the implant, that rod that you can implant into the arm that provides about 3 years of contraceptive cover, became available. Now, as a rural doctor in a public sector area where we see so many unintended pregnancies, this was very exciting. And we were so delighted that this kind of new contraceptive technology was available free of charge to people in the public sector. And we went, at the hospital where I worked, we didn't do primary contraceptive services because those were mostly done at the clinics, but at the hospital we had an HIV clinic. We encouraged most of the women in the HIV clinic who did not want to fall pregnant and who were on, for example, injectable contraceptives like a 2-monthly or 3-monthly injectable to swap over to the implant. We knew that the side effect profile was much lower. We knew that it meant a much lower risk of falling pregnant, and we also knew that the burden on the woman to go back every 3 months or every 2 months to get an injection was much lower. So one injection every 3 years versus 12 or even 18 to do that. So we thought this was going to be a game changer, and we were really excited about rolling Implant-On out, and we really did encourage it in many of our patients as possible. And of course, we did that one-on-one counselling that one should do as a doctor about what needs to be told about the side effects, etc., etc. However, after about 3 to 6 months, the rumours started circulating in the community that I was at in the rural Eastern Cape. One of the rumours is that one of the mums who had an implant implanted, the implant somehow worked its way into the blood vessels and gone into her brain and killed her. Okay, there's no evidence of this ever happening. There's no evidence in the literature of this, but this was the rumour that went around the villages of the Eastern Cape. Secondly, there was also quite a lot of confusion and a lack of understanding of how a rod that's put here in your arm could stop you from falling pregnant. How does this work? What kind of magic is this, right? This seems very strange, okay? And so we suddenly started having more and more women coming back to the hospital, sometimes dozens in a day, who said, no, they don't want this. They've had headaches, they've had bleeding, they've had all kinds of problems, and it must be because of the implant, and they want it out, right? So in that situation, we rushed to implement, and we found that instead of engaging with communities and instead of using civil society to engage and talk to people, to inform them, to speak to traditional leaders, to tell them what this was all about, and to take our time to get that out, we then had a whole lot of people wanting to have it removed, which put a lot of pressure on us as doctors in that area, took a lot of time, and also was quite a waste of money as well. And sadly meant that the biggest impact of the big impact of that we had hoped from the implant was significantly decreased. And that's, I think, is a perfect example of where it's useful to have civil society and community engagement, that we can understand the issues that are there. And that's specifically in the context of government and the context of the executive implementing policies. But I think it's a very good example of how that engagement has to be going forward. All right. Okay. So the last topic that I wanted to cover and talk a bit more about, which comes out of this example, is how do we strengthen the civil society and parliamentary relationship? And I think that there's certainly lots of scope for that, and civil society can help us provide credible research and evidence on emerging issues and implementation gaps, bring community experiences to Parliament, particularly where communities face barriers to participating directly in parliamentary processes, and monitor implementation and bring persistent challenges to Parliament's attention. Parliament, in turn, must create meaningful opportunities for civil society to engage. I think today is one of those opportunities, I hope, and to ensure the stakeholder inputs inform oversight and legislative deliberations. We are grateful to be receiving some of that input today. The relationship should not be one-directional. It should be a two-way engagement, in which Parliament benefits from credible evidence and community perspectives, while civil society has meaningful avenues through which those perspectives can contribute to parliamentary accountability and also to perhaps new legislation. Such engagement must lead to accountability and improved outcomes. Issues raised through public participation and stakeholder engagement should not end when the meeting concludes. Where Parliament identifies implementation gaps, these matters should remain on the oversight agenda, and they mustn't be forgotten by the parliamentary portfolio committees. The executive must be called upon to account for progress, and recommendations should be clear and, where possible, measurable. This requires continuity in oversight. Identifying a problem once is not enough. We must return to important issues and determine whether commitments have been implemented and whether conditions have actually improved. Civil society can also play an important role by monitoring government responses and bringing persistent challenges back to Parliament's attention. So ideally, we should have a feedback loop where evidence is brought to Parliament. Parliament engages with the evidence or the concerns that are raised. Government responds to the concerns or the issues that are raised. Parliament follows up with government and follows up with people on the ground. There is assessment of progress, and that data then feeds back into the evidence that we see, and that there's a continuous feedback cycle like that. This achieving sexual health and sexual, reproductive and health rights cannot be achieved by Parliament alone. It requires collaboration between Parliament, government, civil society, healthcare professionals, researchers, and I think probably most importantly, communities. And each has a distinct role. Parliament provides the legislative framework, exercises oversight, and ensures accountability. The executive is responsible for implementing laws and policies and ensuring that services are delivered effectively. Civil society contributes expertise, advocacy, research, community mobilization, and independent monitoring. Researchers provide evidence and analysis, while healthcare professionals bring practical experience of service delivery. Most importantly, communities must remain at the centre of all efforts, because these policies and programs ultimately exist to improve people's lives. So, in conclusion, Parliament continues to exercise its legislative and oversight responsibilities, sexual, reproductive health and rights remain part of the broader conversation about health equity, human rights, dignity, and access to quality healthcare. Our responsibility is not simply to ask whether policies exist or whether budgets have been allocated. We must ask whether policies are sensible and implementable, are actually being implemented, and whether the resources allocated are reaching the intended beneficiaries. We must also ask whether services are accessible, whether people are able to, and whether people are actually able to exercise their rights in practice. And therefore, we must continue to strengthen this relationship between Parliament and civil society. I therefore encourage all stakeholders to consider how we can work together to strengthen the evidence available to Parliament, bring community experiences into parliamentary processes, identify implementation gaps, support meaningful public participation, and ensure that issues raised are followed through to accountability and to action. Ultimately, our successes should not be measured simply by the number of policies we've adopted or the meetings held or recommendations made. It should be measured by whether people are better able to access sexual and reproductive health and reproductive health services, whether their rights are protected, and whether they experience greater dignity in the health system. I welcome this opportunity for dialogue today, and I encourage all stakeholders to use this platform to identify practical ways in which Parliament and civil society can work together to strengthen accountability, improve access, and ensure that constitutional rights translate into meaning outcomes for all. Thank you.
Thank you, Dr. Leroux. So, I think very quickly, Dr. Leroux reminded us that sexual and reproductive health and rights is not just a health matter. Lawmaking and oversight, he says, must take a multidisciplinary approach, and translating legal and policy frameworks into meaningful access. I think also very importantly reminding us that oversight should be real-time and in local, examining the real experiences of people and communities through interaction. And those that interact with the systems and the services of government, members of parliament should have a real experience of what people on the ground are experiencing in their interactions with the system. He spoke about evidence, the importance of and value of evidence-based decision-making. I think very important for members of parliament, very important for those of us who support members of parliament in their work. Evidence should be credible, it should be reliable. And then, of course, the age-old conversation about meaningful public participation. So, effective communication, the importance of engagement ahead of implementing programs, and engaging with the right people in accessible language. The importance of education before we quickly move to implementation. And then strengthening civil society engagement as well. So thank you very much, Dr. Leroux. Our next input, of course, we cannot have this conversation without our colleagues and friends from the Sonke Gender Justice Civil Society Organization. As most of us know, is an organization working to advance gender equality, human rights, and social justice, with a strong focus on transforming harmful gender norms and engaging men and boys as partners in creating more equitable and just societies. So through its work, Sonke Gender Justice, through its work on sexual and reproductive health and rights, gender-based violence, children's rights, gender transformative approaches, Sonke works alongside communities, civil society organizations, government and other stakeholders to strengthen systems, influence policy and promote accountability for the full realization of rights. It's my pleasure to introduce Ms. Martha Kavuma. She is a regional program specialist on sexual and reproductive health and rights at Sonke Gender Justice. Martha has over 19 years of experience advancing SRHR, gender equality, children's rights, and social justice across Africa, so not only in our country. She has extensive experience in multi-country program leadership, evidence generation, policy advocacy, and strengthening civil society government partnerships for greater accountability and implementation of SRHR commitments. She also holds a Master of Philosophy in Sexual and Reproductive Rights in Africa from the University of Pretoria, as well as a Master's in Public Health Leadership. And Martha brings a strong commitment to evidence-informed, rights-based, and people-centered approaches to SRHR. Welcome, Ms. Kavuma. Thank you.
Is it okay? Do you have space there to put your laptop on?
Yes. The chairperson, honorable members, colleagues, and all protocol observed. Good morning, colleagues. As I've been introduced, I'm called Martha, and I will be making a presentation on behalf of civil society. And my presentation, can you move on to the next slide, please? My presentation is going to be focusing on strengthening civil society's role in advancing sexual and reproductive health and rights. So doctor has really done much of my work. So yeah, so my presentation really will be complementing the presentation that the doctor has made. So before I begin my presentation, I would like, can you move to the next slide, please? I would like to begin with a story, and this is a story of a young girl called Rirato. That's not, it's not the real name, but it's the name of this young girl. And Rirato is a young girl, aged 16 years old. She is still in school. Rirato has dreams for her future. And also Rirato wants to finish school and go to university and build a career of her own. Rirato has a boyfriend. As a 16-year-old, she has a boyfriend. And she wants to have a family, but of course, she doesn't want to have a family now. She wants to have the family in future. So she is not ready to have that family. However, Rirato also has saved some little money. She gets money, pocket money, then she's able to save that money. So one morning, Rirato walks into a health facility, a health clinic, somewhere like 200 kilometers from here. She walks into a health clinic, and she's nervous. As she's walking into that clinic, she's nervous. She has questions. However, she wants to access contraception. She has made an effort to seek information and make a responsible decision about her future. But when she finally gets into the consultation room, she does not experience the dignity, confidentiality, and that she expects to get. Instead, she's questioned. Why do you need contraception? Why are you having sex when you're still in school? Are your parents aware that you're here to seek contraception? And are you planning to sleep around? So these are the many questions that are being asked to this young girl. So Rirato feels judged and she feels embarrassed. And by the way, as she's being asked all these questions, we have people seated in the background somewhere listening to all these questions that are being asked to this young girl. So she feels embarrassed. So Rirato then decides to leave the clinic without the service that she came for. But she does not leave, when her need has been addressed. She lives with her need. So some weeks later, Rirato then discovers that she's pregnant. Now she's frightened about what is going to happen to her future, what will her parents say, what is going to happen to her education as well. And what makes this story, particularly difficult is that Rirato tried to seek help before she needed it. She went to the health system, she sought information, she sought a service. Now, these questions that the health worker asked Rirato may appear ordinary to some of us, but when asked judgmentally, they can turn a health service into an experience of shame. The issue is not whether the health worker needs relevant clinical information that she's gathering, right? But it is whether the young person is treated with dignity, confidentiality, and respect when seeking this service. That's what it is all about. But somewhere between the right that exists on paper and the service experienced in practice, there was definitely a gap in Rirato's experience, right? So, so that story, to some of us, of course, when we were growing up, it's very familiar. But again, as we sit in this room, maybe you know of a young person or even someone who has gone through this experience. And I'm relating this to Rirato, who is 17, but probably there is also a woman out there who probably wanted to seek contraception but was treated in the same way, right? So somehow it speaks to us in one way or the other. So as, please move to the next slide. As we move then to the next slide, when you look at Rrirato's story, it has a lot of issues around the systematic accountability. that goes throughout this story. And so it then just reflects to us that, real change happens when each and every link in Lerato's story is strong. So if we have a weak system at the clinic level, that system is going to affect Lerato right from the start up until the end. So if we have, we have good laws, they're implemented well, then we'll not have a Lerato who is experiencing this challenge at the community level. Move to the next slide, please. So when we look at Lerato's story, and I'm drawing my presentation to Lerato's story because this is a lived experience of a girl in a community where we serve our people. It raises different questions, and the bigger question for us is what happens when the rights and commitments we have made do not translate into the experiences of the people that we are serving at the clinic level, because that's where it all starts, and that's where it all should end. Because Lerato's story is not simply about contraception, and it is not simply about contraception. It's not simply about that one health worker. It's not simply about that one clinic. That one clinic, that single Lerato, that single contraception represents a whole lot of SRHR issues, as Doctor was, indicating them. So it's all about that. And it also raises, several questions for us. And the questions are, what does it mean to have a right which we cannot experience, right? Which we cannot enjoy? Yes, the right is there on paper, but we can't enjoy it. So what is the purpose of the right anyway, in the first place? So on one side, of course, we have the policies, we have the laws, we have all these good strategies, all these good commitments that we have made, we have asserted to as a country. But on the other hand, we have the lived experiences of people. And the lived experiences of people are the ones that tell us where our progress is. If we have all these good documents on paper, but the lived experiences, if one person comes and says, for me, it is this, then we are not meeting our commitment. Just last week, I was speaking to one of the young persons, and this young person actually told me, for me, I don't use any service that is being promoted by government. And I'm like, that's a big statement. And then I'm like, why is it? Because whatever is being promoted by government has a motive behind it. And can you imagine, this is one young person, but maybe this is now a narrative that is going on in the community. And as just, Doctor, you were narrating that story about the contraception and all that. So someone starts with that narrative and it goes around in community. And so for me, that was a big statement to say, how can someone say, I cannot use a service that is being promoted by government? So if government says for example, we have these COVID vaccines, bring them, then the person, no, we go to the community and say, you can't use them because they have a string attached to it, and therefore the community won't use it. So that's a very big, So as civil society, then we ask the questions in Lerato's story. Where is the implementation working, and where is it not working? Where is it failing? Why are we failing our people? Why are we failing our young people? What is being left behind? So those are some of the questions that we, then ask ourselves. And this takes me to my next slide, which talks about the reality and the promise that we have made to the South African people. So in my next slide, talks about the reality and the promise. And of course, perhaps for some of us, the members of parliament, when we go back to our constituencies, sometimes we see that picture of, our people lining up for services, right? And, when you look at that picture of people lining up for that service, that picture, aside from many people lining up for the service, to access a service at a clinic, it is also mixed. In that line, you will find a young person of 15 years. In that line, you will find their mother. In that line, you will find a person living with disability. In that line, you will find an elderly person. So all of us, we are in that queue, which, again, speaks to, is this service really? Because if I'm a young person standing beside my mother or my aunt, am I really going to be able to have that confidentiality that I need to access this service? So that is the reality on ground. But on the other hand, we have a promise, the promise that the South African government has promised, and I'm looking at only the Constitution because it's our mother document. That's where every other policy comes from, where everybody has the right to have access to reproductive health care services, including reproductive, care. So all the policies, they come out of this mother document. But does the word everyone really, when we go to our communities, does it really apply? That's a question for us today. And why is it that term everyone, that word everyone, does not apply to everyone in reality if you look at that picture? So moving on to the next slide. So we look at then our South African landscape in terms of the progress versus the gaps where we are right now. So we cannot stand here, of course, and say that South Africa has not made very good, improvements and has not made progress. South Africa has actually made very good progress in terms of issues around reproductive health, and one of those is that we all know that South Africa has one of the best and liberalized constitution in the region, but also in the world. That one is a given and it's a guaranteed. And for us, that's a very good starting point. We also have very good policies. We have ascended to so many commitments as a country. That is already a good step where we are heading in the right direction. In terms of the expanded services and infrastructure, South Africa has, infrastructure. We cannot deny the fact that South Africa has put up infrastructure, health infrastructure, and, to be able to reach, our communities. I mean, the recent rollout of the ART, not so many African countries have been able to roll out that. In terms of the SRHR services, the contraception, we have a very good liberalized law which allows young people, even the abortion, the termination of pregnancy policy. Those are all policies that are very liberalized and they are very good where South Africa has really made, positive, the maternal health. Yes, well, of course, we cannot say that we have reached where we want to be, but our maternal health, status has really, declined. For example, moving from 148 per 100,000 deaths for mothers to now 108, around there. So there is a lot of, progress that has been made under our maternal mortality as well. In terms of civil society, we have a vibrant and active, civil society that is able to advocate. This, you don't find it in so many countries, and I want to compare it with many countries in the region because, I have the opportunity to work elsewhere, so I am able to do that comparison. Then also we have an active youth and community engagement network within the communities where we work. So there is a lot, and these are just a few of the progress that South Africa has made, and we need to be proud of what progress that we have made. However, we still have gaps in the progress that we have made. And one of those gaps is the issue around the persistent barriers, to accessing the service, which I was talking about. Even in Nerato's, story, you find that there were issues around confidentiality, issues around, access itself. When you go to the service that is being provided here in Cape Town CBD, when you go 200 kilometers from here, I don't think you will find the same service. Right, so there are lots of gaps in terms of geographically, financially, the structural barriers that limit access to services. The rural areas versus the urban areas, we still have gaps in there. Then also the other one is around the issue again around the inequalities and the social norms. We all know that South Africa is a patriarchal society, and therefore the norms, the social norms, are really they shape who we are and the services that we give. For example, if I'm a health worker and I'm a strong Christian, right? If a young person walked up to me, I already have in my head, you're not supposed to have sex before marriage. So that attitude really forms the service that I'll give. So the social norms are still entrenched in our society, and therefore we need to be able to see how do we address those so that they do not limit access to services. And then also the other issue is around the weak, of course, implementation and accountability. Like I noted, we have like so many very liberal laws, very nice policies and all that, but do we really implement these laws in full as we are supposed to? And then also the other issue is around the backlash and the shrinking civic space. In the recent past, we have had a lot of the anti-rights movements, coming up on the continent. Even in South Africa, they are here. The anti-rights movements, they are here. Although it's only when you get in that space when you actually realize that actually these anti-rights movements are here. But if you're not in that space, you would not know. So, and these anti-rights movements are well funded. They are well funded, they are well connected, to such an extent that in some of the countries, they actually have access to the presidents and to the first ladies. And whatever they say actually forms the policies of those countries, right? So that is something that we really need to see how do we safeguard as a country, that they do not penetrate to even reach policymakers, to even reach, the powers that be, to then form policies based on, those narratives. So it was so interesting last week when we were in a meeting in Mombasa, and we were having this meeting with the religious and cultural leaders, and from 25 countries. And it was so interesting when we brought up this discussion, most of the countries were raising up their hands to say, yes, they also came and had a very big conference in our country. They went to the president, they went to the first lady, they are always engaging with the first. And when they sit in those inner chambers with the first lady, with the president, because you don't know what they are negotiating and discussing. So it is already here with us, and therefore we need to see how do we safeguard, the anti-rights. Can you move on, please? Then also in my next slide, then I talk about, although Doctor has already preempted my slide, so I'll just summarize. How do we see civil society? Civil society, I would call it the eyes and ears, on the ground. Civil society, lives with the communities. We live with the communities, we interact with the communities. And civil society, when you look at it, they are non-political institutions. And therefore, we are able to have the trust of the communities, because we live with them, we engage with them, and they're able to listen to us. And therefore, the role, we as civil society, our role really, moves from just a listening, society to an action-oriented civil society that fights for the rights of our community members. And therefore, when you look at my first column of the slide, number 1, we're looking at local communities, and these local communities, that's where civil society lives, because we live with the communities. So we live with the communities, So our role when we live with the communities, we gather information with the communities. We are able to understand, what are the issues, at the community level. We are trusted with the community structures, and the local structures trust us to even tell us things that they may not ordinarily tell, either politicians or even other, So that role that we play in the community is very vital, because then it helps us to see how do we ensure that we use that strong point that we have as civil society to be able to go through all the accountability mechanisms up to that stage where, we have improved health outcomes of our communities. Then also, as civil society, we are able to collect data, and I think that is also something that Dr. spoke about. We collect data, but as we're collecting data, of course, we are collecting data through our program implementations, through our, when we go to health facilities and we are working with health facilities. So we collect data in different ways, and we ensure that our data is also credible, and also our data, also has issues around consent and privacy. And then also that data that we collect, again, when you look at number 3, is then, forwarded to national and provincial systems, which then helps the national and provincial systems to analyze the data. As they analyze the data, they disaggregate the data, then they're able to also get insights into the data that we provide, and then also then generate evidence from the data. And then they are able to develop, the national and provincial systems are able to develop, budgets, policies, and then also to form implementation at that. Then also then it moves then from number 3, from the provincial, now that's where Parliament comes in, using this particular data to be able now to provide, the Parliament, the DHIS, the Chapter 9 institutions, and so on. Now that's when they come in, because now these are the levels of the national oversight and accountability. This is where also accountability takes place. Then the Parliament is supposed to use that particular data to see how do they monitor the budgets. Also ask questions. If a budget is being presented is $1 million, for example, for SRHR, what was your justification to provide this 1 million? What was the data you based on to get this? So Parliament asks questions based on that data, and also ensures that there is accountability and provides an oversight role. Then at the end of the day, if the work of the civil society actually does not stop at community or at developing data, but it actually goes through, because even civil society can then also come to Parliament and say, Parliament, you say this and this and this is what happened, so where are we, Parliament, So again, civil society is very critical in also questioning Parliament to say, how do we ensure that oversight ensures that the implementation and we have the sexual and reproductive health outcomes, So at the end of it all, again, when you look at down there, there is that feedback loop, the accountability and feedback loop. Again, civil society has a bigger role to also go back to the community, again, to provide feedback, to say, we came here, we collected this data, this is what we did with the data that we collected, and this is what has happened. The health center has been improved, there's contraception in the health center, there are youth-friendly services at the health center. So civil society has that role, and that critical role that it plays to connect, community with the accounting, officers, and the accounting and the government, and so on. So that is, the role of civil society, and that role has to be strengthened. And of course, civil society, we need to also be able to strengthen that role that we play. So going on to the next slide, which talks about the synergy loop, how can then Parliament and civil society then work together? So again, I will not repeat what Dr. said. He gave a clear description of what Parliament's role is, and then also what civil society role is. But I just quickly go through the circle. So the synergy, so Parliament and civil society do not work in isolation, because we all have different strengths and we all have different work that we do. As Parliament provides the oversights and holds accountable, the policy makers, civil society, we have to be able to generate that data that Doctor spoke about, that data that is credible data, because if we don't provide credible data, then it is going to mislead every single step in the loop. Right? So Parliament and civil society have that role of working together side by side, but not as complementary. Right? We bring the information, we feed the members of Parliament are then able to put, to question. So looking at the first slide, the first box that talks about community evidence and monitoring. So CSOs, of course, gather information. Of course, I spoke about that. And as CSOs gather the information in the second, box, which is labeled number 2, there is joint oversight. Now, Parliament and civil society can actually do joint oversights. And we can do joint oversight just to say, okay, we are going to such and such a clinic as members of Parliament and civil society, just to check what we have been, advocating for as civil society, what Parliament has been questioning, has it actually been, implemented. So with that data, we are able to do joint, to do a joint oversight visits. Then also the evidence based committee, during the evidence committee, hearings again. This is the role of Parliament, right? But again, when Parliament goes to those hearings, when Parliament does the APPs, they need data from the civil society again. Credible data from civil society for them to be able to question the budgets, to be able to do those APPs, right? And therefore, then we work hand in hand, right, on that. Then also the issue, again, around budget tracking again, the Parliament, of course, does the budget trackings and also the expenditures and also safeguards grants and all that. So, and then at the end of the day, in number 5, we find where there is that box that talks about policy, budget, and service delivery. So and this circle continues, it doesn't stop. It continues because each and every time you have a different issue. Today it could be contraception, tomorrow it could be ART. So the circle continues, it doesn't stop. And at the end of the day, until we see that there is improved, SRHR outcomes for our communities, the circle does not stop. So, and therefore, we as Parliament and civil society, we really need to see how do we practically work together to be able to achieve this, because there is no any one person who can actually achieve, these results without the other. The next slide talks about, reclaiming the shared imperatives. And in this slide, of course, again, Dr. did mention that, at the center of all the work that we are doing, both civil society and Parliament, is the dignity of our people. That should be our common goal. Whether we are from this party or what, the common goal should be that our people have that dignity, to be able to access the right that they are promised. At the heart of the work that we do, citizens have to be at the center of the work that we do. Those young women, the young girls, the young boys, the persons living with disabilities, the rural communities, the marginalized populations, all have to be at the center of the work that we do. And therefore, what are we saying? We are saying that there should be at least 3 shared narratives, imperatives that we are proposing. One, how can we institutionalize, our dialogues, as members as Parliament, as civil society? Do we have time to engage with each other, and in a sustainable way? And whenever we engage on each other, how do we ensure that we have actionable points? If we are saying that we are going to be meeting after 6 months, what are we going to be doing in those 6 months? So that by the time we come back after 6 months, we have actions that have been, rather than just meeting here, we go away after 6 months, we come back and talk about the same issue, right? So how do we ensure that we institutionalize our dialogues? And then also, how do we ensure that we put the vulnerable people first? That's a very important thing that we really need to think about. And also we need to be able to ensure that equality and dignity is at the heart of each and every initiative that we do as Parliament and as civil society. And then how are we able to turn our commitments into outcomes? We have committed to providing everyone the right to health. How do we ensure that is practically done? Not on paper, but practically done. So those are the shares. So as I conclude, I have 3 points that I would really want us to reflect on, and one of those, please can you go to the next slide? And one of those is about we have made strong commitments. However, those strong commitments that we have made still have real challenges. So how do we ensure that, South Africa's strong commitments, this very nice constitution, the liberal constitution and policies is actually implemented, and implemented for everyone, not segmented, but for everyone. Then also the other one is, the community evidence and systems that we provide. How do we ensure that there is oversight? And this oversight that we provide really strengthens, the work of Parliament, strengthens the work of the civil society, and strengthens our communities as well. Then the third one is about, partnership. Partnership creates greater impact. And like I mentioned, civil society and Parliament, we all have different roles. I cannot do the role of a doctor here. I can't. Even if you are to teach me, I wouldn't, because that's not where my passion is. And probably the doctor the same. So we all have different roles, but how do we ensure that our roles complement each other? We are not walking, in parallel. We are all, heading to the same destination. So, just to conclude, then at the beginning, I introduced you to Lerato, a young woman who encountered the gap between a right on paper and the right in practice. The purpose of civil society engagement is to help ensure that the gap does not remain invisible, and that community experiences become evidence, evidence becomes accountability, and accountability becomes change. If rights are to have meaning, they must be experienced in people's everyday lives. And if Parliament is to exercise effective oversight, the voices and the evidence from those everyday experiences must reach the places where decisions are made. Thank you very much.
Thank you, Mr. Kabuma. I think colleagues, Martha introduced us to a very compelling story of 16-year-old Lerato, which illustrates the real experiences of too many girls and women, and I would argue boys and men, in accessing healthcare services and exercising their rights. She spoke about systemic accountability and debunking the judgment and stigmatization and shame of accessing SRHR services, and then moving from there to reinforcing and guaranteeing confidentiality and dignity, and translating rights to practice and access. And then she reflected on some of the key progress on SRHR in South Africa, and reminded us of the gaps that we still need to address. And then spoke very importantly of the importance of and value of sustained partnerships and collaboration with civil society organizations, particularly for collecting and providing reliable, credible data that, in a sense, from an evidence-based platform, it depoliticizes SRHR and the tracking of progress and moving from progress to outcome. And turning commitments into outcomes. On a lighter note, Martha, you spoke to access to presidents and their first ladies. Hopefully soon, and I dare to say in our lifetime, we will start talking about presidents and their first men. So, we live in hope. And then she left us with a call to action on those three very important points. Thank you. I'm going to move, we're a little bit ahead of time, but I'm going to call on Hannah again to introduce a project that she's been working on, dealing with SRHR, HIV and AIDS, and governance. Hannah, thanks.
Do I have a HDMI cable here? Sorry, is anyone from ICT able to assist me for a second? Anybody have? Somebody need to flight it for me.
Yes, I can.
Oh yeah, I think speak from here, but I don't think there's a cable.
Thank you.
Yeah.
Can present from comfort. All right. Is it showing? Good. What's going on? It's not working. It was working.
Screen is off, maybe can we switch off?
Yeah, it looks like
Sorry, can somebody please check the screen? Aha, we have live.
There we go,
All
there we
right.
go.
Sorry about that. All right, so just to introduce myself again, my name is Hannah Walby, and my title is the Research and Project Officer for what is known as the SRHR, HIV AIDS and Governance Project, which is run by SADC Parliamentary Forum. So this event is part of that project, and I will be talking today a bit about what it entails, what the goal is, and how you all can hopefully play a role in trying to promote SRHR at a national level. So as some background to this project, SRHR recognized lagging achievement of SRHR in its member states, and so applied and succeeded in obtaining funding from the Swedish International Development Cooperation Agency, or SIDA for short. They went on to commence the first phase of their project from 2014 to 2018, followed by the second phase in 2019. So we are now in the third phase, which runs from 2023 to 2026. And it was recognized that previous phases of the project succeeded in ushering in new SRHR promotive legislation, increasing budgeting, and increasing political interest. However, SRHR saw that work was still required to ensure universal access to SRHR, especially when it comes to the right to information, and that pertains to comprehensive sexuality education in schools specifically, as well as safe abortion and rights for LGBTQI+ individuals. There's also this growing issue of climate change and how that intersects with SRHR, and so that was added as an additional focus for the third phase of the project going forward. So this project exists within a network of partnerships. Obviously, we have all the member states within SRHR, so there is somebody like me existing with all the participating member states, but then there are also all these UN bodies, NGOs, academics, and research institutions. It's really a collaborative effort, so it's always encouraged to partner and have this collective effort in order to meet the objectives of the project. Speaking of which, these are the 6 key themes or goals of the project. So I'll be going through all of these in more detail, but briefly, we have the first one, which is to do with commodity security. Then there's gender equality, elimination of child marriage, early and unintended pregnancies, and safe abortion, right to information, protecting key populations and marginalized groups, and lastly, democratic accountability and human rights. The point I'd like to make here, though, is that these are all interconnected and mutually reinforcing. So, for example, first pillar of commodity security, which refers to contraception, medications, tests, and so on, that would help enable the elimination of early and unintended pregnancies. For example, if somebody like Lorato is able to access the contraception that they are seeking, or the information that they might receive in the school or in the clinic helps them, it improves gender equality, the second pillar here, and eliminates child marriage and so on. Alright, so starting with this first pillar here, commodities refer to the essential supplies required for SRHR. As I mentioned, this includes contraception, family planning products, tests and treatments for STIs, including HIV, as well as maternal health medicines. And then commodity security naturally means that there is universal access to safe, affordable, and high-quality commodities. And this contributes to the broader goal of having universal SRH health coverage. Second pillar refers to gender equality and gender-based violence and femicide elimination, including within climate action. And this came about given the interconnected nature between SRHR and gender equality, with both contributing to each other and relying on one another. Climate change was added to this project, as I mentioned, within this last phase, given that we are seeing the gendered effects of climate change. It is not a gender-neutral phenomenon. Women and girls are most impacted due to the social inequalities and biological vulnerabilities that they experience, and this affects their health. We see more pregnancy complications and preterm births, but also poorer socioeconomic health. So girls will be the first to be taken out of schools, for example, when their families are struggling and they need to be put to work to support their families. Women and girls are often the ones responsible for farming, fetching fuel, fetching water, and preparing food. So they are the first to be hit when climate starts to compromise these abilities. There's also this quite interesting link between climate change and climate disasters and gender-based violence. We see increased stress and resource shortages, as well as displacement of individuals and communities altogether, culminating in greater violence, particularly towards women and girls. However, at the same time, women frequently lead community-level conservation efforts, And we've seen that local projects and policies in which women are involved in decision-making actually result in better environmental outcomes, all of which highlights the necessity of including more women and girls in climate action. The last aspect of this theme refers to gender-based violence and femicide, which in South Africa was declared a national crisis in 2019 and a national disaster in 2025 by President Ramaphosa, making this a state priority. You may be familiar with some of the rather harrowing statistics of over 1 in 3 South African women experiencing violence during their lifetime and over 1 in 10 experiencing sexual violence specifically. And South Africa is, we see that femicide rate is almost 5 times the global average. So this makes gender-based violence and femicide a crucial area to be addressed within this project. And Parliament then can play a role in promoting legal and policy frameworks in which gender and climate change are linked. So we need more gender considerations in climate management and action policies, and vice versa, we need more climate considerations in gender-focused policies. Moving on to that third pillar regarding child marriage, early and unintended pregnancies, and safe abortion. South Africa does have one of the lowest rates of child marriages in Africa, but it does still persist due to legal loopholes, cultural traditions, and socioeconomic factors. Early and unintended pregnancies are, however, an ongoing challenge for our country. We have one of the highest rates of adolescent pregnancy in the world, although this has actually been dropping over the past 4 years. We recently learned, so this is promising. And we see this issue of early and unintended pregnancies coming up, for example, in the statutory rape inquiry, which is currently underway at Parliament. And then abortion, or termination of pregnancy as it's known more clinically, became legal in 1996, making us one of the few African countries where it is available upon request within limits. And this has been shown to contribute to a major reduction in maternal death and disability. However, as has been mentioned, it comes down to implementation where stigma or conscientious objection among healthcare workers, lack of information, and rather aggressive marketing of legal services makes this far from a reality for many people who are seeking the service. Unfortunately, the most recent data I could find was from 2017, but this did show that less than 7% of public health facilities actually provided abortion services, with more than half of abortions occurring informally in likely unsafe situations. The fourth theme here refers to the right to information regarding SRHR. Information is a key aspect of SRHR. It refers to the ability to receive accurate, accessible information regarding one's body, sexuality, reproduction, and healthcare. Comprehensive Sexuality Education, or CSE, is quite a large aspect of this and has been quite a contentious issue within society, making it something that the project does focus on. So for those who are unfamiliar, CSE refers to the provision of age-appropriate, scientific and stigma-free education regarding puberty, reproduction and relationships to young people in schools. And it should technically be available in all schools in South Africa through life orientation. Some of you may remember receiving it yourself. However, as I mentioned, there's been severe public pushback as relates to religious conflicts, teacher discomfort, and a lack of teacher training. The fifth pillar here refers to key and marginalized populations. And these are the people who are most at risk of poor SRHR outcomes, such as sex workers, people who inject drugs, LGBTQI plus people, particularly gay and bisexual men and trans women, as well as young people, especially girls, and quite pertinent here in South Africa, migrants. We see, just jumping ahead to this point here on migrants, Operation Dudula outright denying access to services for migrants. The same is often true of young people who receive stigma and judgment within healthcare facilities. When it comes to sex workers, they are still criminalized and therefore also denied services at some points. Drug users are punished rather than rehabilitated, and gender and sexual diverse people receive incredible amounts of stigma and discrimination in healthcare facilities and broader society, as well as, and we see increasing rates of criminalization throughout Africa, rather than the opposite, which is definitely an area that deserves focus here. So just expanding a little bit more on the experiences of LGBTQI plus individuals, we will be hearing more from one of our civil society speakers later today, but the discrimination they face can be within the healthcare facility itself, where they may be discouraged or outright denied from accessing care. They might be abused, and they might just simply not be able to access the services they need, such as gender affirming care or pre or post exposure prophylaxis for HIV/AIDS exposure. Within broader society as well, the violence and discrimination they experience puts them at higher risk of poverty and drug use, which altogether contributes to poorer SRHR outcomes. And the last theme here refers to the promotion of democratic accountability and human rights. SRHR are considered central to human rights and democratic governance, as well as the other way around, strong democracy and human rights is central to SRHR. These refer specifically or especially to the rights regarding bodily autonomy, equality, and the right to information. For this reason, SRHR is considered a key indicator of a healthy, inclusive democracy, as it allows for the full civic and political participation of all society members. For this reason, parliaments are tasked with the promotion of constitutional values as well as the advancement of anti-corruption frameworks as part of this project. So how exactly are parliaments expected to operate in this project? We can link the outcomes I've just mentioned to the 4 basic functions of Parliament, which I'm sure we are all somewhat familiar with: legislation, oversight, budgets, and representation. These can all be linked to SRHR, for example, reinforcing weak SRHR laws, such as those regarding child marriage, promoting safe abortion and commodity security, eradicating gender-based violence and femicide, upscaling budgets, exercising strong oversight, especially when it comes to that commodity security, gender-responsive climate action, and the protection of marginalized populations. There also needs to be more engagement of underrepresented communities on SRHR issues, and there needs to be greater generation and use of empirical SRHR and HIV research. Practically speaking, this can look like a range of project activities which can be tailored to the South African context and our goals. These can be, for example, roundtable meetings and multi-stakeholder workshops, such as what we have here today, where we bring in civil society, we could have academia, we could have key and marginalized populations all come together to learn and engage. There can also be public awareness campaigns, outreach projects, public hearings, and so on. Just to mention that this does exist within a formal theory of change where specific outputs are linked to outcomes, impacts, and the broader vision of promoting universal access to integrated SRHR and HIV/AIDS services. And so specific activities can be seen within this overarching framework. But without further ado, that is it from me. I hope that we can all take something from today and try to relate it to the work that we do, and hopefully we can form some collaborations going forward and together go further to advance SRHR. Thank you very much.
Thank you, Hannah, for unpacking the details of the SRHR, HIV/AIDS and Governance Project. As I indicated in the opening remarks, it's a project that's nearing the end of phase 3, as Hannah has also indicated, and hopefully it will continue. We're still in engagement with SADC-PF, the Secretary General there on that matter. But even if it's not continued through the SADC-PF program, we're hoping that we would be able to integrate this work into our parliamentary administration and the work of committees. I think a very important point that Hannah raises is that this is not something that should be driven only by the parliamentary administration and civil society. We really need members of parliament and committees of parliament to be the champion of this kind of work. As the parliamentary officials, we charge with providing the data and the support and the research, but it's really for members of parliament to take this up and not only through oversight, but also looking at the review of key legislation and introduce amendments to bills if it's required. And again, that's where we would come in and support those processes as the parliamentary staff. All right, as I said, we are running quite a bit ahead of time, but I think it gives us more opportunity for engagement. I want to now open the floor for not only questions, but also input. And please ask that you introduce yourself, indicate where you're from or who you're representing, and we'll have an open discussion. Thank you so much. I have a hand here first. Any other hands at this point? Honourable Member, let's go ahead.
Okay, great. Thank you very much. Good morning, everybody. My name is Samantha Graham-Murray. I'm a Member of Parliament. I serve on the portfolio of Women, Youth and Persons with Disabilities and on social development. And I think this is a fantastic conversation to be having. I think it's really important. I also represent a rural constituency in the Eastern Cape called Dr. Beyers Naudé, which includes 8 small towns. And I really enjoyed Martha's story about Lerato because it was one of the things I was going to raise, particularly in small towns where your nurses at your clinics know everybody. So young girls coming in to get contraception are judged, they are embarrassed, they are treated badly, and then leave without it and get pregnant. So we are seeing that as a prevalent issue in the smaller towns. The other thing that we've had in the rural communities is that a lot of our farms are serviced with mobile clinics. And what happens every year is that the Department of Health fails to renew its vehicle licenses. And so the mobile, all the clinics are out of service. So the mobile clinics then don't get to the farms. And we find then following that, there's a massive upswing in pregnancies of farm workers because they haven't had access to contraception. So it is something that needs to be looked at quite seriously, is how are we making sure that the people in remote areas that are serviced by mobile services are getting access to those on a regular basis so that they can make the adequate plans in case they're not. So I just wanted to, and thank you very much for all the inputs. I think they're excellent. Thank you.
I think there are also the other dimensions of the individual risks to one's health when this erratic kind of starting a medication and then having to stop it for lack of access and then restarting it. So there's so many dimensions to the continuity of care, or that whole continuum of services. And I mean simple things like keeping your vehicle registration up to date. I mean, those things really shouldn't be falling through the cracks. So it's about holding the officials and the structures accountable.
Excuse me, everybody. I really don't want to dominate the whole conversation. But also in the rural areas where we are, the lack of ambulance services is a massive issue. So ambulances in the Eastern Cape are allocated on a numerical basis, so 1 ambulance per 10,000 residents or whatever. But for example, we've got 8 towns in our area, and some of them have only got just over 1,000 residents or 2,000 residents. So they do not have an ambulance. So we are seeing infant mortality and maternal mortality rates in those areas because there's no ambulance. I mean, there was a woman in Graaff-Reinet, I got called to say that she was giving labour, premature labour, not giving labour, she was in labour, and they'd called for an ambulance, the ambulance never arrived, and she literally, the baby died in her house 3 kilometers from the hospital, let me tell you, 3 kilometers, and we could not get an ambulance out to this house. So ambulances are becoming an increasing concern for rural communities and the health of the people in them. Thank you.
I had another hand. Yeah, go ahead, sir. And one at the back. Thanks.
Thanks so much, Chair. The first thing that I want, my name is Sikangele, and my surname is Mapulu. By the way, I'm also Johan. When I was baptized, they called me Johan. The first thing that I wanted to say is that as much as we know that the Parliament they are made to make the law, I think you are excelling in terms of that. I think that was attested by most of the presentation that the laws of the Parliament are superb. However, we are in experience of the challenges of that to make sure that the departments that are supposed to do 1, 2, 3, they are not doing effectively, and it might be different as reasonable. And that's so. Most of the presentation have been attest also that. But the question is that I wanted us to ask is how many adolescents are turned away from the HR, referring to the Lerato story. They are turning away from the SRHR services each year. Do we have that question? Because, and how many complaints have been received regarding the confidential breaches? So, do you have those statistics? So, if we don't have those statistics, issues of pregnancies, the steps that have been taken when the people get pregnant. If we do have all of those questions, if we don't have the questions, then how inform the decision that we can make? Because we don't have those questions. Because I can tell you that there's a lot of evidence base that people, the institutions like tertiary institutions, they're making a lot of research there and there. But are those research coming in front so that you can be able to take informed decisions? I must say that from the last thing that the issue of the SRHR is not a burden also for health, but it's also a burden for other issues like the recent statistics of the matric last year. It was open to say that we've got a lot of people that are dropping out because of the pregnancy. And dropping out means that you might not able to come back in school. You'll be a burden of the government. The youth unemployment, the poverty issues, the maternal death, HIV infections, gender-based violence, etc. So we tackle it as one thing, but also you can be able to prevent a lot of things if we focus more on issues of the SRH. Thanks so much.
Thank you for that. And I do want to invite the presenters to interact with the inputs as you want to. It's Jacques at the back. Thanks.
Jacques from Research Unit. Just the questions aimed towards the civil society, but please, it's open more there. What is civil society and others' experiences with the district development model in terms of SRHR and traditional councils? Because it seems like a lot of argument is about the culture and the way of life in areas impacting the people. So has the district development model at all been used as a vehicle, especially by civil society? Has there been space for civil society to bring this up there, or even from political level? And then secondly, the basic question that's asked everywhere, artificial intelligence, how's that assisting with dealing with matters such as these? To track progress, to identify that. Is maybe the thing that we need a robot to provide it to people so there's no judgment? Is that maybe the only way that we are going to go forward with this? That's me, thank you.
All right, thank you for that. I don't know how we're going to manage this, but in terms of the recording and the sound on the camera also, because we're streaming, for those seats that don't have microphones at the back, if you can. No, there is there a roving mic? Let's just get that so that we can also get. It is there. All right. Okay. Any reflections, Dr. LaRue, at this stage? Thanks.
Thank you. Just on the comment made by the gentleman here, I think that it is, I sometimes think of health as we sometimes putting a plaster over a gushing wound, and there's a lot of societal issues that we need to take on in terms of choice around sex, in terms of socioeconomic challenges, in terms of situations where young women are in relationships where, in the so-called blessed relationships, where there's a imbalance. And so I think there's a lot of things that I think we can put plasters on some things. We can help by educating young people about sex, and we can make services available to them, and we need to make sure that those are accessible and are welcoming rather than kind of judgmental. But I think that this is really a big societal question that we need to deal with more broadly than just, as we have said several times, than health. So I just want to kind of echo what you were saying, and I think that it is a big challenge, and I think it's got to do with socioeconomic development. It's got to do with good education. It's keeping people in schools. I just from my perspective, it was as a rural doctor, having young women giving birth in our hospital, we have this interesting conundrum, because we want those young women to go back to school and finish school. We also want to make sure that their children survive. And so I ended up always having a discussion with the mother, and with the mother who gave birth, and usually her mother who came along to come and fetch her from the hospital, to say, like, what are we going to do now? Where are we going with this? I'm not sure if you've been in school or not for the last few months. Remember that breastfeeding your child is crucial, especially if you live in a rural context, right? If you live in a rural context, and if you're not breastfeeding your child exclusively and you're giving your child formula, there's often not access to clean water. And so the risks of dying from diarrhea and pneumonia are high. And so I would often say to these young mums, this is the situation where you find yourself in, and it's a tough situation, and you're going to need lots of help from your family. But my recommendation is that this year is a year of breastfeeding. So we get that child to an age where they're a bit stronger, and then you go back to school. We don't want you to stop and fall out of school completely. And so we encourage the grandmothers and the mothers to work together. But we have to have those conversations, and those are tough conversations to have, and complicated situations, such as conversations to have. But we have to find the balance between looking after this baby who's very vulnerable, and if that young girl goes straight back to school, and the grandmother is giving this child formula from 2 weeks onwards, that puts that baby at significant risk as well. So there are lots of complex issues there, and I think that we need to continue having those conversations, and I think that those things often need to be discussed in communities. I think that we can't solve all these problems as government, but we can certainly be providing support and solutions in some ways. So yeah, thank you.
Thank you, Dr. Drew. I think there's also the issue of where do we enter the system? What is the touch point? That we've been having conversations around the curricula for the training and development of healthcare workers, including medical doctors. It might resonate for you that in our medical training, you have a very small snippet of taking sexual histories, which is a very awkward conversation, particularly when you're a student doctor or a young doctor in clinical practice, and you're speaking to women and men that are much, much older than you are, asking about their sexual history and their sexual habits and so on. So often that conversation is missed, because even the healthcare workers are uncomfortable with the conversation. So there's misdiagnoses, there's missed access to services, there's missed opportunities for people accessing the system to actually ask the questions that are foremost in their minds. And therefore, there's an onus on the healthcare workers to actually introduce the conversation in a responsible way and a non-judgmental way. And I think there's very little training for healthcare professionals in the curriculum for this kind of thing. Ms. Martha Kavuma, thanks.
Okay, thank you very much, Chair. I just wanted to make a comment on the probably the question that my colleague raised around the statistics. That do we really have the exact statistics, for example, for contraception use, for the teenage pregnancies, for unsafe abortion and all that? I think we don't. And if a country actually said that they had the exact statistics, I think I would question those statistics, because many we sample. We do a sample, and I think also that is basically because the resource basket that we have cannot allow us. If we wanted to sample all, for example, that 20 million women in South Africa, we may not be able to do that because we don't have the resources. Civil society, as much as we want to gather all this data, all this information, we don't have the resources. And in the recent past, our basket has been shrinking. We all know that civil society, we get money from, donors, right? And in the recent past, the US did major cuts, which actually affected most of the civil society, funding. Most of the research institutions were actually getting funding from USAID, and all that money was cut short. And that means that there is a deficit. So even as for as much as we want to get all the data that we want to get, but we may not be able to get it. And that's why in the recent past now we are actually pushing for governments to increase that resource basket. We are pushing for domestication of funding, and for us we're saying South Africa cannot tell us they don't have the money. The money is there, but how are we prioritizing? Where are we putting our money? Are we putting this money in ensuring that the health status of our masses is improved, or we are putting it somewhere else? And I think that is now the job of Parliament to start questioning, because also aside from, big governments like the US cutting their funding, again, it's kind of like just happened that every other big funder also started cutting funding. We had a very good funder, the Dutch, they changed their policy. They cut their funding. They were really so generous funders, but they just decided to change their policy, and they cut majority of the funding. So now, how do we now ensure that we start pushing our governments to start allocating money for this? Because again, also the other thing is that South Africa is not, I don't know whether it's unfortunate or I think it's fortunate, is not one of those countries where funders are so keen to fund, because they say South Africa is a developing country, and therefore the need here is less than other developing countries, and therefore accessing funding, is now becoming a challenge. So how do we now ensure that we have domesticated funding to support the CSOs to be able to generate that, the accurate data that we need, to implement the policies that we want to implement. So I just wanted to add on top of that, we are challenged as civil society for as much as we want to do this, but the resources are not there anymore. So how do we support each other? How can government support us to do the work that they cannot do, to go down to the communities? And then we also, are able to support government to realize their commitments. Yeah.
Yeah, Hannah, go ahead, and I'll take the other hands.
Just to add maybe a bit of context regarding what you've been discussing, which is widely known as the anti-rights movement or anti-rights network. It's something that has been coming up more and more nowadays. My colleague Princess and I, who's a gender equity researcher, we were attending the SADC workshop on this anti-rights movement with other member parliaments, and just to add to the comments already made, this is affecting funding, but it's also affecting, well, organizations and networks are popping up across the continent with this anti-rights, anti-SRHR agenda, and the goal is to shrink the civic space and to ultimately compromise gender equality and the gains that we've already made. So something like this project is becoming increasingly important as the support shrinks. And to be able to garner more political support and these political champions that we have here today is becoming more and more urgent. To be able to recognize that SRHR is not an isolated issue. It is linked to economic development, it's linked to rights, education, social development, and to be able to, as we've been discussing, these interlinkages are very real, and in some sense it doesn't actually make sense to be separating SRHR as an isolated issue. It is part of broader health and broader development, but more and more we have these moralistic, cultural, religious notions that are countering the goal of SRHR, so we need to try and protect it as an important goal and keep garnering this political support. I think that's what I wanted to say.
Thanks. I think it's important that it's one of the reasons why it's located in a rights-based framework. I have the honourable member up front here, and then I'll take your hand, ma'am. There was a hand at the back as well. So, honourable member, madam, and sir. Okay.
Thank you very much. Thank you very much, Chair. My name is Feza Gambiko. I'm the Member of Parliament. I'm also involved a lot with the rural communities. And mine is just to stress the importance of confidentiality between the health worker and the patient. In most times, you'll find that these patients, they are scared, as it was stated here before, to go to the clinic, because even the health workers and those in charge, they come from the very same community. I go there with my problem in the morning. By the time they knock off, everybody knows that so-and-so was at the clinic, and he or she is suffering from this and that and that and that. I don't know how that could be stressed more. If there is a way, they can also even apply a fine if that information gets out, so that they stop doing what they are doing there in the clinics. And now these things, they make these patients, they become scared to go to the clinic because they know that it won't be confidential, whatever sicknesses that they are experiencing. And one of the challenges is the closing times of the clinics. Most people in the communities, they don't have vehicles. You find that one, young lady, or even if it's a older woman, if one is in labor, the clinic will be closed. Now what will need to happen is what Honorable Graham Murray has stated earlier, that the ambulance has to be called. In my area, I'm 200 kilometers from East London, and I have a local hospital which is 50 kilometers, from my home. But what will need to happen is that whoever requires the ambulance, has to call the ambulance that call East London, which is very, 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 very far. And while they are doing that, the ambulances are parked here in the Butterworth Hospital. But they can't go out and fetch whoever because they have not been instructed by the East London, which is 200 kilometers away. You know, so whoever wants an ambulance has, and you know what? It's an emergency number, but you don't go through quickly. It takes time to even get through to that emergency number. By the time you get there, you know, whoever was like ill or whoever was about to give birth, the damage has been done. So there are those things, you know, the closing of the clinics, closing times, and the unavailability of ambulances. It puts much more pressure and stress on the community. So those are my points. Thank you.
Thank you.
Thank you very much, Chairperson. My name is Makosazane Katele. I serve on Portfolio Committee on Women, Youth and Persons with Disability. I would like to thank the presenters for the informative and insightful presentation. The issues raised are very important, particularly regarding SRHR, gender-based violence and femicide, access to healthcare services, and the protection of marginalized groups. I would like to raise a few questions and make some inputs. I think my first input or question will go as this implementation. That's the problematic part of implementation. South Africa has progressive SHR legislation, but implementation remains a challenge. What practical measures can Parliament take to ensure that these rights translate into accessible service, particularly in rural and disadvantaged communities? Secondly, it's a budget. I think the one that Martha was talking about. How can Parliament strengthen oversight of SRHR budget to ensure that funding reaches the people and programs that need it most? And my input as well will be, I think Parliament should redirect the resources towards this project. Marginalized groups, what mechanism can Parliament put in place to ensure that migrants, young people, LGBTQI persons, sex workers, and other marginalized groups are not discriminated and against when accessing healthcare? And the other point, comprehensive sexuality education. That is very important. It must not end here with us as members of Parliament. It must go outside to the masses. How can we strengthen teacher training and public engagement to ensure that comprehensive sexuality education is delivered accurate, appropriate, and without stigma? Safe abortion, the following point, give the gap between the legislation and actual access to services. What can Parliament do to address shortages of trained healthcare workers, stigma, and conscious objection? We do have a gap. Even in schools, we do schools where children live with a disability. We don't have enough healthcare workers. That's the challenge that we are having. I think our government must concentrate on healthcare workers. Gender-based violence and femicide. What stronger parliamentary interventions are needed to ensure that GBV commitments are translated into measurable outcomes and effective services for survivors. Climate change, how can Parliament ensure that climate change policies properly consider their impact on women, girls, and other vulnerable groups, particularly in rural communities? Research and data, how can we improve the collection and use of reliable SRH and HIV data so that Parliament can make evidence-based law, policies, and budget. I would like to emphasize that Parliament must move beyond legislation and commitments towards implementation and accountability. As members of Parliament, we have an important role through legislation, oversight, budgeting, and representation. Thank you very much, Chairperson. Thank you.
Thank you, Honourable Member. I think some very pertinent questions that you pose to the room, but also I think individually in our different roles as we play within Parliament and beyond. I've noted your hand, Ms. Paulson. I'll take this gentleman. Thank you.
My name is Oversight from Portfolio Committee of Women, Youth and Disability, and also SNDF. According to my, there is a hospital which is called Albert Lutuli in KZN. I visited there. I noticed that there is a tracker will come to collect some people who are ill and disabled. But when you go to Mshini Hospital, people are traveling almost 1 kilometer in the steep hill, especially disabled people and people who are totally pregnant, which is not right at all. Would you please assist those people to get some transport to like charging like Albert to take the sick people from the hospital to the taxi rank up there by the hill? That is not right, what I really noticed. I also concerned about an ex-soldier who's abusing her wife. I got her wife's number, is afraid because the soldier is willing to kill her. Will you please intervene to that? Because some soldiers are trained and I can't explain about soldiers because some of them, they can kill himself and the children and the wife. Will you please try to stop that? I got the number of that woman too. I also concerned about the special schools. People living with a disability are totally left behind. In Lincoln's special school at Umlazi, people on the wheelchair got no bathroom. If he or she need to go to the bathroom, the teacher is responsible to carry her or him on her back to the bathroom. It is totally unaccepted. I also concerned about doing visiting to the people. We can go this year and you find the problem. Even next year, the problem is not solved. If we keep on visiting the people and get their complaint and not resolved, each and every year you find that you have to go and do a gratuity, go and do a visiting. You only find the same problem. People see as if we are not serious about them, but when they come to vote, we need them first. Especially disabled people, they always consider the first priority in the voting. We even visit them in their homes for voting, but when you come to an assistance, you leave them behind. How can you make this first priority to assist us? We always say that we have nothing for us without us. Please consider us. Please consider us. I also visited Lincoln School, a mother of a child who was born disabled. When the child reaches 18 years, they said he must go and renew he or her grant. I wish the daughter is here, he can intervene to those such things. If a person was born disabled, that must continue not being renewed because some people are living in rural area. If a person his grant is closed, you have to hire a car, a wheelchair, and an assistant. A taxi charges a lot of money, whereas the money they got is not enough for surviving. Thank you.
Thank you, Honourable Member. There are some individual, very specific issues that you've raised. I think out of this meeting, we must just get information from you and see how we can assist in moving that forward. It illustrates the importance of having parliamentary mechanisms where, when members conduct individual oversight, as a member of parliament doing your constituency work, how does that come back into the parliamentary system? So we must facilitate that as well. Ms. Paulson.
Thank you, Dr. Gabriel. My name is Berenice Paulsa. I am the Senior Researcher for the Social Services and Infrastructure Cluster in Parliament. I want to start off by reminding us that this year, I think it's 30 years since the Termination of Pregnancy Act was passed, and at the time it was very controversial. Subsequently, there were various studies that were undertaken around and by civil society around the implementation of the Termination of Pregnancy Act, and it also showed that especially young women had difficulty with accessing the service. And so a couple of years ago, Parliament, the Parliamentary Research Unit, it's more than 10 years now, we conducted a survey, a study. It was a twin study that we undertook in the Eastern Cape and one in the Western Cape. And the intention was to determine whether, and the focus was on young adolescent girls living on farms. And the study wanted to determine whether there was a difference in geographical space with respect to urban versus rural, but also in the different provinces when it comes to knowledge on sexual and reproductive health in general, and then in particular the Termination of Pregnancy Act. What was very interesting was that there was a significant difference in the adolescents that were surveyed in the Eastern Cape versus the Western Cape. And the only difference was that in the Eastern Cape, you had a major civil society organization, it wasn't the Planned Parenthood, but there was a civil society organization that was doing advocacy work with young women. And the level of knowledge around sexual and reproductive health rights, but also in general termination of pregnancy, was significantly higher in the Eastern Cape, where the civil society organization was very active in the community. At the time, it was also quite evident that there were the level of stigma and ignorance around and myths around termination of pregnancy was quite it's quite revealing. When we ended up in the Eastern Cape and were doing this study, a group of older women who were not meant to be part of the study announced themselves, and they insisted that we also include them as part of the study, and so of course we did. And I remember the conversation was that the older women in the community were really the gatekeepers for access to, or denial of access to termination of pregnancy. And they felt very strong, and again, the issue around the religious, socio-cultural beliefs playing a very strong role. I remember one of the most, the statements that had such a significant impact on me is one of the mothers was saying that even if her child experienced sexual violence, she would not agree to a termination of pregnancy. And so I think the sense is that firstly, we need to also determine at this stage, 30 years later, has there been a significant change? What we also did as part of the study, which was interesting, was we also surveyed the health service providers, and even amongst the health professionals, there was also resistance. And in fact, one of them told us that she would discourage any young person who attempted to access termination and share with her any other options that there is. And so that also served as a major barrier to access to reproductive health services, but also termination of pregnancy. So in essence, I think what I'm saying is that the issues that colleagues raised today, especially around the barriers that are experienced for young people to access sexual and reproductive health and rights services, those are very real, and it echoes some of these, the sentiments that were raised this morning. Thank you.
Thank you very much. I'm going to take the 3 hands that have been raised, and then we'll get some responses and reflections from the colleagues. Brindley, I'll take you first, and then Esther at the back, and then I'll give you another opportunity, so thanks.
Thank you, Chair. Apologies. Good morning. Yeah, I'm still good for morning. Good morning to everyone here. Thank you so much for the opportunity. I want to say thank you to the speakers who have shared incredibly important information, particularly at a time where globally conversations and discourses around social reproduction, social reproductive health and rights are undergoing targeted and sustained strategic coordinated attack. And I think that is the entry point for perhaps my inputs that I would like to make, and I'll be rather brief, because I'm not known to be brief, actually. But I think one of the key considerations around the importance of this work is related to the global discourses, and it's been mentioned about surrounding the anti-rights movement. Oh, I didn't introduce myself. Sorry, I'm Brindley Fortuin, and I'm from the Public Education Office at Parliament. And so one of the key ways in which I would look at the challenge that we're facing is through the lens of what education, and particularly various forms of community-centered education, can do in relation to the anti-rights movement. Of course, a lot of the sentiments that I have comes from on the heels of the fourth African Interparliamentary Conference on Sovereignty and Values, advancing the African Charter for Family Values. And so my biggest concern here is that continentally, there are these national regressive discourses utilized, injected into various countries' national discourses, and circulated at, for example, an interparliamentary conference. And so my input would be on 2 levels. On one hand, I think what would be useful for us is to think through the ways in which rights discourses are used in order to consolidate hate. And so while the rights-based discourse is open to us to combat it, and we can do so with our liberal constitution, which affords us really protective rights, it is the same legal instrument in the end that is used to peddle regressive hate. Not in our case, but it is present. And I think Martha made a very astute observation to say that it is present in South Africa as well. That even now, that same conference that denies, that conceptualizes and defines the family in a very heteronormative, heterosexual way, is trying to be held in South Africa, in Cape Town, which in many ways is a bastion of considered LGBTIQA plus progressive politics on the continent. And so if these parliamentary conferences happen, and they happen within corridors of power, they make recommendations, and they want their recommendations to be taken up to the AU. And there are certain comments that are, recommendations that are made to COSPAL as well. We do need to think in terms of the work and the direction that we take in Parliament. We do need to think about how do we, in line with Parliament's values of being a transformative Parliament, how do we bring that transformative agenda into those particular halls of power and where those conferences are happening. But at the same time, there is a very particular argument to be made for civil society as well. And so if we're looking at the massive funding cuts that happen internationally, but also very distressed economic realities on the national scale, the question becomes how can Parliament better support community mobilization and civil society in order, through collaboration, to do very particular work. And so I'm thinking, if we're looking from the viewpoint of public education and public participation, which are constitutional mandates of Parliament, one of the ways that we can do that is through creating that meaningful space, utilizing the resources that we have in Parliament to set the scene. I believe that we have a very, very robust LGBTIQA plus civil society in South Africa. And so convening them together and providing particular chartered pathways in which to address and to advocate and to strengthen what accountability and oversight might look like is in the best interest of all of us, regionally, but also continentally, as we have that particular responsibility towards people like me who live in other countries where there are more criminalized and regressive contexts. And so I would be very excited during the course of today, but also tomorrow, and following this particular and important launch that we're having here, to see how the notion of education plays a critical role in opposing the grand narratives, the funded narratives, the strategic narratives that are circulating continentally, regionally, but also nationally. And the Public Education Office would be very excited to work in that regard to ensure that when there is meaningful public participation, when there is meaningful oversight and accountability, that there is a coordinated and systemic approach towards combating the anti-rights movement. But I will end off with saying I don't necessarily believe that Parliament should be the one leading that. I do believe that it is civil society which should. And so when the partnership and the collaboration is thought of and conceptualized and strengthened, I think one of the key ways is that Parliament should be guided by civil society and by social movements, and through that partnership leverage the strengths that both have towards that common goal. Yeah, thank you.
Thank you, Brindley. Colleagues, that was, if you know Brindley, that was his example of brevity. But thank you, Brindley. I think you raise important issues. And I think the critical issue of particularly funders that have their own agenda oftentimes and their own program, predetermined programs for countries. So it is a challenge that faces civil society where funding is required, but then it comes with certain parameters and restrictions. so the idea of domesticating funding, I think, is a critical, as Martha has raised. Esther, I'll take your hand, and then the gentleman, and then we'll have some feedback from the presenters, or reflections and responses, and then I think we will be in time for lunch. Esther?
Policy and legal framework. Can you hear me now?
It's very soft, Esther.
Sorry about that. I just wanted to agree with Mr. Wilma from Somke Gender Justice that, we do have a very solid policy and legal framework when it comes to sexual and reproductive health rights. But I do think that sometimes our legislation has unintended consequences. And sometimes it doesn't take into account the realities on the ground. And I want to also use an example of the Children's Act, for example. If you look at the provisions of the Children's Act, it cuts across sectors. And I think the main problem that we have as a parliament is the way that our committees operate in silos. I think what is called for in some cases is integrated lawmaking and integrated oversight. If I take, for example, I just had a look, and I'm sorry, my name is Esther, and I work also in the research unit as a senior researcher. If I look at the Children's Act, and I'm talking now specifically about social, cultural, and religious practices provided for in Section 12 of the Children's Act. I think that is, for example, an act that should have, although it's managed by the Social Development Department, but when Parliament considered the legislation, it really should have gotten a number of sector committees together. If I look, for example, at Section 12 in particular, it speaks about virginity testing. It basically amounts to consensual virginity testing by girls over the age of 16. But if you look in the cultural context, and I'm latching onto words such as dignity, I'm latching onto words such as patriarchy, etc. How realistic is it that a girl, especially in terms of, the basis of the practice, for example, it promotes abstinence really more than sexual education than anything else. And so in my mind, had the Arts and Culture Committee, for example, been involved in the passing of that legislation, they probably would have been able to advise the committee that that provision not very realistic. There is no such thing as consensual virginity testing. If you think about the stigma that a girl might face, if you think about in the patriarchal context that a girl might not be able to refuse realistically, then how realistic is our legislation? And so, my main point is really that I think Parliament needs to move from conducting oversight and passing legislation in silos to a more integrated approach of doing things. And just based on the amount of oversight kits that we found beautifully printed and displayed up front, I know that there is, different parts for different sectors and committees. There's different points of the value chain where committees come into play, but I think there are just those kinds of issues where integrated oversight is required, and I think that is where we are lacking. And then specifically, I wanted to ask, I'm not in the sector at all, but I don't recall having seen oversight of potentially harmful cultural, religious, and social practices, and I just wanted to hear what is the role and the type of evidence that civil society can bring to the table to ensure that that gets onto the program or onto the agenda of Parliament. Also around the last issue, Dr. Gabriel, access to services in rural areas. I know of a small rural town where even if you have medical aid, you can't get access to a pap smear. And we know that a pap smear is a gateway. Can't identify cervical cancer, but that's exactly at least where it starts. If abnormal cells are detected, you go for further tests. So there's no such services, and if there's any suspicion of any form of cancer, you have to travel to a hospital 3 hours away. And that is fine for the person who has access to resources. I'm thinking of the normal, ordinary woman in the rural area. And I'm not sure what it is that Parliament can do with regard to oversight of that kind of issue. I think that was it. Thank you.
Thank you.
Thanks, Mr. Chair. Just wanted to acknowledge the hearing. When we speak about Parliament, when we speak about the way it's called out of order and unparliamentary, point of correction, and all of that. But I can see here while you are talking, you're very friendly. Even if you are out, then you'll be make sure that you collect the information as much as you can. That's why sometimes we don't talk because we're afraid of those things. But the first thing that I wanted to say, Chair, is I was inspired by Edward Mabunda, the guy from KZN who was living with HIV. And that guy was nearly to die in 2003. And this guy said in Parliament, we were marching in Parliament before we take that action. He said in front of the Parliament, you see, I'm going to die anytime now because my CD4 count is going down, And Edward Mabunda, the following day, we heard the news at the time that Edward Mabunda couldn't survive after 3 days that he said that in front of the Parliament. I think we know the struggle of HIV or what happens, but eventually there was improvement of the the government approved the treatment. So, in other words, I wanted to say I was inspired by her. Today, I'm proud to say that I'm a wellness center coordinator leading this, running the men's clinic, and through that inspired. And today, I've been inspired by the story of Lerato, because Lerato is a 17-year-old knowing that I have a rights to go to the clinic and get the services from the clinic. But when she arrived at the clinic, that's something else that is coming from the clinic. I'm inspired by her because I've got 3 children, daughters. All of them, they passed that stage. The last one is 19 years old now. All of them, when they come, they start the precautions. They will come to the date, say, Daddy, I've got a problem in the clinic. I went to the clinic and such question and other thing, and I have to accompany them to the clinic, to the nurse to say, I give the permission, you must take care of my children when they come here. So all of them, 3 of them. So Lerato just signed off the story that this thing is happening in South Africa, where the young youth, when they go, the young girls, they don't get an access. But the big question that I said to you earlier is that even though was my old child now is 24 years, it's 5 years down the line, or 5 to 6 years down the line, we still don't have something tangible to say, this is the issues that are coming out from the clinic. Others can share their stories, whatever stories. So now we should be all inspired about Lerato as we speak now, and should write a note to say, no more Lerato tomorrow. Because Lerato represented many South Africans, young girls. And in that words, I wanted to put it forward that at least the Parliament should have effective oversights. The effective oversight visits. Not because of we wanted to dot down and to say, right, I was there at the clinic and all of them, but effective a visit. And also review the adolescents SRH service delivery. What really happens there? A monitor, implement of the policies. Because South African National Health Act is there. And there's a lot of statutes out of that. So is these things happening on the ground? So that's a question. It's not now a question of resources, whether we have how many nurses, how many doctors, how many things. The question is, what we have, can we implement it in the clinic to ensure the adequate budget? Because now we talk about, you cannot work without budget. You cannot work without structures, like to say, meaning to say, coordination groups, Also require regular reports from the Department of Health that this thing is happening, and especially to the issue of the teenage pregnancy. Remember, we already attest that I said it before that this is happening, and it is the issue of teenage pregnancy is not only affecting the issue of the SRHR, but it's affecting across the board, and also engage with the education. I am proud to say, South African, to say, after I went to the traditional circumcision, but I've named there, I've got a lot of names there, get a new name when I went to circumcision. But I saw my foreskin is partially cutted. So I was like, it's a taboo language in our country, in our culture, to say you're going to cut foreskin again. But I did it because of education. So I have to cut it, my foreskin again. So what I'm trying to say that education is very important, because Lerato go to there for services, but when Lerato arrive in the clinic, there should be an education to Lerato. Say, by the way, condom usage. By the way, this thing happening. Is this happening in the clinic, or children just go to the queue to inject themselves and all of that? So these are the things that I wanted to say, that education shape the mindset and shape the people's life. The end thing that I wanted to say to Parliament, because I see I'm not going to give an opportunity, that the Parliament must not only ask whether the SRHR policies exist, but it must ask whether Lerato and thousands of young South Africans can access those services without fear, without stigma, and without judgment as well, without discrimination. So, lastly, guys, because I don't want to come here again to be asked, where are these people? Because sometimes when you come here with placards, you don't even know our faces. Who is this now? I was here, explaining myself, I'm Sekangele Mabulu, but now when I come with the placards, say, hey, Lerato, and then come to you to say, guys, we're enough. It's enough now. So we prevented that, because it doesn't really assist us, because it's just giving us a line in between to say these are them, these are us, because it's our thing. So let's really focus on this thing, because we know, and we already all know, we understand each other when you say that this issue can also prevent a lot of the things. Thank you very much, Chair.
Thank you. I have further inspirations. Did both of you have your hands up? Lady in the front? Or just one? Okay, go ahead.
Thanks. I think I'm inspired by what the gentleman has just said. My name is Mpoma Tabat. I'm the content advisor for Correctional Services Portfolio Committee. He spoke about the need for effective oversight. And I think for me, what we need to focus on is perhaps maybe we need to have a collaborative and share best practices in terms of oversight for committees. And I think the starting point for me would be for researchers as well as content advisors to collaborate in their small corners, share their experiences and best practices. And maybe at a later stage, you might need to look at formalizing that particular aspect of sharing best practices in terms of oversight. I think if we formalize it, then it's something that can be us. And secondly, Chair, is the issue around, and I could see already that the House has forgotten it. Oversight on those society has decided that we need to lock them up and throw away the key. Those are people in correctional facilities, but not only those, also people who are in refugee camps, people who are in Lindela repatriation facilities, youth in Department of Social Development, those who are youth at risk. I think we also need to zoom into those in terms of access to healthcare of those particular individuals. I think fortunately for the Portfolio Committee on Correctional Services, oversight is conducted on correctional facilities, but in this case particularly on facilities incarcerating women and youth. And when they conduct oversight, focus is also paid to healthcare facilities within those institutions. Your hospitals in correctional facilities to look at the services that are offered to female offenders and youth. But I think the question that we need to also ask is whether access to health care for people who are in confined spaces, is it a right or is it a privilege? And if it's a right, we really need to ensure that oversight is conducted in those, to ensure that that particular access, as promised in our constitution and other legislations, is realized. And I would also want to encourage, especially Portfolio Committee on Health, in fact, Portfolio Committee on Home Affairs, to visit those Lindela repatriation centers and zoom into issues of access to healthcare for those people who are confined in those spaces. And lastly, the Portfolio Committee on Social Development to visit those youth at-risk facilities to look at access to healthcare of those young people who are at risk. Thanks, Chair.
Thank you. Okay, we have 5 minutes to our scheduled lunch break, so I'll take the last two hands and then some quick reflections from the panelists. I'll take you, Madam, first, and then finally, gentlemen at the back. Thanks.
Thank you, Chair. My name is Micheline Pagona. I'm an activist and I work most with migrant community and the locals in terms of health rights. Mine, it's a suggestion. If they can be a youth-friendly clinic. So I think the issue of Lerato, it's going to be addressed a bit because the young people these days, you have the technology and that also can help. They can have an app that they can have their question answered. So that will help rather than having maybe someone at my age, maybe I still have those old thoughts that I was told when I was young, but these days things have changed. So to have those kind of friendly clinic for young people, the same way we have this, the victim support room at the police station or the Tutuzela Care Center, those are friendly areas. So if we can have for young people, because we see that they are the most affected. And when it comes to the migrant community, it's an information maybe some people, they don't know, because these are the minority. We have, myself as a migrant, we have cultures where a woman does not have a right to her own body. For you to go for contraceptive or for you to go to the clinic, for you to go anything which goes with your body, your partners must first approve. If it does not, you don't go. And we have women who are really suffering. For this month of Women's Month, we did organize a community dialogue with migrant women to talk about the cervical cancer, the breast cancer. It was so surprising they don't have an idea. So that's also, it's another point to bring. And because people, they are not educated maybe on HIV, and so it's because they are living in community with others. So, and the language barrier plays a big role in there. Thank you.
Thank you. I think there's a very important point being raised around, particularly the last two inputs, on how we define and identify key populations, because it's not a universal definition, and it depends largely on the service that one is providing. Let's take the last hand. Thanks.
Good afternoon. Bakota Khania from ISSD. Constitutions are driven by rights, consideration, and principles. And embedding the rights part in policies and programs can really drive commitment globally. Policies and programs from other countries and funders may accept multiple negative consequences in other countries, like receiving countries, as we have seen how the research was distracted when the US pulled out the fundings. So sexual and reproductive health services cannot be suspended because the sexual and reproductive health activities and needs do not stop. If countries own their independent policies and programs on sexual and reproductive health and integrated the rights components and implement and defend the right-based approach, continuity of sexual reproductive care, and realization of the dream for sexual and reproductive health and its impact can be accelerated. So in that manner, there has to be a flow from governments or institutions such as Parliament into what other countries or funders that believe in the same rights or in the same line should ensure that the rights part, because that's what holds them accountable. That's what seeks commitment from these parliamentarians and from our governments. Thank you.
Thank you. Okay. I'm going to start with you, Ms. Kavuma. Some reflections, and if you have any specific responses to some of the matters raised, and then over to you, Dr. Leroux, after that, and Hannah, if you have any input on things.
Okay, thank you very much, Chair. Chair, I would like to begin with a point that Micheline raised around, migrant communities, and yes, which speaks a lot to the inclusivity, and I think a gentleman there spoke also around the issues around how do we ensure that we include everyone, the uniformed men, the people in prisons, everybody. How do we ensure that inclusivity is actualized? And speaking specifically to the migrant communities, one thing is for sure: when people migrate, we migrate with our cultures. We don't leave our cultures. At home, we migrate with them. And therefore, if you have migrant communities, for example, that are people who are coming from, let's say, Somalia, people who are coming from Eastern Africa, or even West Africa, by the way, their cultures of FGM, the female genital mutilation, that they do. And it's a standard, it's a given, it's part of their culture. They come to South Africa, they migrate with that culture. and they start doing the FGM. So if in our planning, in our, we don't consider them, they are moving with those cultures here, and those cultures will actually have a bigger implication, for example, on the maternal mortality. So we really need to see how do we include everybody, because even the Constitution of South Africa says everyone. So and when the Constitution says everyone, it is everyone, whether you're a migrant, whether you're in prison, whether you're a long truck driver, it is everyone. So how do we ensure that that aspect of everyone actually covers everyone in its implementation? Honourables spoke about the issue of, asked quite a number of questions. How can Parliament, practically, ensure that there is accountability? And I would like to go back to again what Honourable mentioned around the issues. When there is need for an ambulance, they have to call someone who is 200 kilometers away, or even when there are women who also need ambulances to go to the farm. To get women to take them to the health, they are not able to access them because the ambulances, the alliances are not renewed. So for me, as a member of Parliament, again, you can correct me here if I'm wrong. My point of call would be, if I'm a member of Parliament, I want to have a healthy community that votes for, a health constituents that votes for me. And if my constituents has grievances, has issues around access to health care, which is the fundamental, because if you have people who cannot be able to wake up in the morning to come and vote for you, then that's a problem. So how can you, as a member of Parliament, when you go back to your constituents, ensure that these services that are actually put there to benefit your constituencies are actually actualized? If a health clinic or a hospital is denying people to have access because they need to seek consent from someone who is 200 kilometers away. And by the way, in South Africa, again, you can correct me if I'm wrong, we have a decentralized system of health care where, decisions have to be made at the health center, not at the national level, not at the provincial level, not at the district level, but at that health center. That is what the health system in South Africa is. So if we still have challenges, those structural challenges that you have to call someone 200 kilometers away to seek approval to release an ambulance, that's already a problem. And how can we, as members of Parliament, when we go back to our constituencies, try to question that? And as Chair said, then when you go there to do those visits, you come back to Parliament and say, I went to my community, this is what I found out. Now I want this table put on the agenda to ensure my community has ambulances, So that becomes your point of advocacy as a member of Parliament in Parliament. So, and that way, of course, some of these issues appear to be abstract, but they can be done. They can be done. And probably some of these, all of us are not going to wake up and do the same thing, but those baby steps we take, each one of us, at the end of the day, can help us to have a broader. So how can we practically, we as members of Parliament, again, go and question, that implementation at that health facility? Again, in terms of, there's a colleague who spoke about the review of the termination of pregnancy that they did. I happen to do also one, reviewing the safe abortion following the liberalization of the Termination of Pregnancy Act. And when I did that research, it was so interesting that I live in Pretoria, but I go so much in Johannesburg. When you go to Johannesburg, mainly in Johannesburg CBD, every single street in Johannesburg, you find those placards, messages saying, painless abortion. And what? In fact, that is what prompted me to do that research. I'm like, how can an abortion be painless? How can it be? So in my head, I was like, how can it be painless? But these are messages that people see. And as people continue seeing these messages, they actually also buy that, actually, I can have a painless abortion. And they also advertise to say that they can terminate pregnancies for up to 6 months. and this is painless. So I do this research, and I went to, interesting, I went and interfaced with some of those people who do those backstreet abortions. And this guy kept on convincing me, even if you're, 8 months old, we can terminate the pregnancy, it is painless. And I'm like, oh my God, that's where we are having a lot of, our young, children dying, our young adults dying because of this misinformation. And why do they actually seek this information? They seek it because when they go to the health facility, as Honorable said, there is no confidentiality. By the time I walk in there, everybody will know she had come to terminate a pregnancy. So they would rather go to a backstreet person who will not actually say anything, get their money, they'll keep their mouth shut. So as members of parliament, how do we, again, when you look at, you're in that constituency where you have lots of backstreet abortion, because everybody knows them. In the community, everybody knows them. So how do we ensure that even those backstreet, abortion providers, we try as much as possible to, to quote unquote, eliminate them from our society, because they are the ones, again, who are facilitating, the unsafe abortions, which are, at the end of the day, again, contributing to the high levels of maternal mortality that we are still seeing in the country. So again, how do we fight that as individual members of parliament, in our constituencies? Again, one of the colleagues asked a question of where does the interfaith and cultural institutions fall. I think for us, mainly the interfaith, the cultural institutions, they all fall under civil society because we work with them. So I wouldn't really put them under parliamentary, but they actually, it's a big institution because we all know that our society, is really built on cultural institutions, is built on faith, and therefore that is a very big sector that we work with as civil society. We have faith-based organizations, again, that are also taking leadership in some of these initiatives and working very well with CSOs that are not faith-inclined or culturally inclined, but and they are actually, taking the lead in fighting, for this cause, to ensure that their congregation, their communities are living healthy lives. Yeah. So that's what I can say about it. Yeah.
Thank you. I think you've covered a lot there, and I don't have that much to add. I think that, thank you for the feedback. I think there's several broad issues that have been raised, and many comments, and I'm not going to comment on everything that was mentioned or raised. I think that the one thing to say is I've seen there's several practical concerns about services that are being provided, and I think that I'm always nervous when we kind of come with a whole lot of requests and think that government can solve everything. And so I think that for me, I think we need to be thoughtful about what's there, understand the context in which we find ourselves with distance, with small populations and communities as well. But I think we need to be innovative as well. I think that we don't necessarily need a fully, a lot of transport to hospital. I mean, that lady who died 3 kilometers away from the hospital, the baby who delivered, that probably we could have just got her into a little van and got her there. And so I think there are innovative ways that don't require, fit into what we think should happen. It doesn't have to be a fully fledged ambulance to get a person 3 kilometers from one place to the other to get the care that they require. So I think that's just one small example, but I think we do need to think out of the box and not just inside the kind of boxes that we are used to thinking. I think I also want to recognize and say that, in some of the comments made, is that sexual and reproductive health is a contested space. And I think that there are communities, there are parents, there are religious groups, there are civil society groups that all have different perspectives and belief systems around this. And I think that we need to give space for that discussion to happen. So I'm a little bit uncomfortable when we talk about not platforming people. I think we are all kind of demonizing certain religious groups or certain people for having beliefs that we might not agree with. I think it's important that those, as part of a democratic and pluralistic society, that we give space for those conversations to happen, because within the context of our society and our constitution, and I'm a little bit uncomfortable with the term anti-rights movement, because a lot of those people would say, no, we're fighting for the rights of biological women, for example, or so I think we need to be thoughtful and engage, and as soon as we say these kind of views are deplorable, we actually create a bigger monster. And I think we've seen that in Europe. We've seen how right-wing parties have been, far-right parties have been pushed aside, and what happens when they don't get a chance to be part of the political debate is they grow dramatically, and people put their votes in those areas, particularly, for example, in countries like Sweden, where the far-right party there was deplatformed, and people just kept voting. More and more people voted for them. I think that if our ideas are good, we must debate them in the public square, and our arguments need to be strong enough to win those arguments, rather than saying that those ideas are deplorable and we don't want to listen to them. Yeah, I think those are my main points. Thank you for all the inputs, and I look forward to further discussions after lunch.
Yes, I'll be as brief as possible. I know we all want to get to lunch now. And luckily, we do have another plenary session later at the end of the day, and this lunchtime and beyond, hopefully, to continue these really important discussions. I just wanted to very briefly speak to the topic of improving implementation of SRHR services, and I mean the whole aim of these two events is to improve SRHR oversight through increasing the collaboration with civil society and communities, being able to draw on the knowledge and experience of civil society and have a stronger relationship with them, and more generally just to build a common knowledge base among support staff, MPs, civil society, so that we all have a common starting place in order to engage on these issues and to understand where we fit into the protection and promotion of SRHR. We'll also be having a formal launch of these toolkits that have been mentioned a few times now and are starting to drift around, I see. But these are looking at the individual core committees, those who are working most closely with SRHR, including correctional services and police, in order to look at all the ways that oversight can be enhanced. And I think this will be a really valuable tool or resource for us going forward. But yes, this issue of actually increasing engagement across these silos is critical, and I'm really glad that it has been brought up now, because it is definitely something we need to think more about and start hopefully implementing and developing some more formal processes around. And then lastly, just to mention, there were some questions about climate change and SRHR, as well as cervical cancer. These are actually issues that we've touched on previously in the project. We had a webinar in April, I believe, this year on climate change and SRHR with some experts on the subject, and we developed a report with some very practical recommendations for how the integration of gender and climate can be enhanced. So I'd be happy to share that with anyone interested. And then I also developed a research brief on cervical cancer, looking at where things stand in South Africa, what the implementation gaps are, and making some more general recommendations about ways that we can enhance the implementation of policies and services. So yeah, that's it from me. I hope we can continue the discussion later.
Thank you very much, and let me thank you all for the vibrant discussion and the panelists for the inputs as well. It's now 12:46. I want to suggest that we break for lunch, and can we be back at 1:30? We were scheduled to be back at 1:15. Let's take our full lunch till 1:30, and then we'll try to make up the time and still finish on time as scheduled. Thank you very much. Lunch is outside.
Okay. As a the purpose of this presentation is to introduce, and also we're formally launching today, the toolkits for sexual and reproductive health and rights for core parliamentary committees. One of the realities is that while the outcomes for sexual and reproductive health rights is shared between different sectors, the mandate and the money is located in different departments. And as we discussed this morning, it's not often very concrete what each core department's role is when it comes to sexual and reproductive health rights. And so why do we need a toolkit for sexual and reproductive health rights? Next slide, please. Is that we know how we spent as a country this year for 2026-27, our budget was 310 billion rand for health. That is about 19.4 billion US dollars when we reported to SADC how much we spend as a country. We indicated, but that is still below the 15% that South Africa needs to spend on health in terms of the Abuja Declaration. I think our spending, consolidated spending was about 11 point something percentage. And I also agreed, we discussed this morning, that sexual and reproductive health is about human rights and it's about improving the lives of everybody, but especially the most vulnerable people in our community, in our society. So we're launching today, as indicated, our sexual and reproductive health toolkits for core departments. Core departments, for the purposes of this presentation, are defined as those departments where a significant portion of their expenditure goes towards sexual and reproductive health rights and rights services. We've come up, as you can see, we have the toolkits, and if you go outside, you'll see on the table, there's a copy of the toolkit for the core departments. Of course, health is the custodian in South Africa for sexual and reproductive health rights. And then we have the toolkit for the health department. We developed one, and the question was asked around correctional services this morning. We developed a toolkit specifically for the correctional services committees. The Home Affairs Committee, basic services, as you can see, the South African Police Services and the Department of Social Development. Of course, this is not an exhaustive list of sectors or departments that contribute to the sexual and reproductive health and rights outcomes. We would like to, at a later stage, add the Justice Committee, the Department of Women, Youth and Persons Living with Disabilities, etc. But next slide, please, Hannah. So the question is, we do spend a lot of money on it, and for purposes of this presentation, we also realized that how do we assist committees with asking the right questions? Sexual reproductive health rights is a shared outcome, but we do know that it's not a shared mandate. And the different departments contribute differently in different functions and they have different programs. And this means that if we want to ensure that sexual and reproductive health and rights do get the attention, the focus that they deserve, we thought that it would assist committees if we come out of sector-specific oversight toolkits, which are aligned to the various mandates of the parliamentary committees. So the problem, of course, with a generic toolkit would have been, the challenge would have been that you cannot capture everything in a generic toolkit. And we wanted really to go to a very detailed level. As you can see, if you peruse the toolkit, you will see that it's very specific for each of those sector committees. The idea is to help parliamentary committees to ask targeted, evidence-based oversight questions and thereby support more effective, accountable, and impact-focused parliamentary oversight. Thank you. So, the series of toolkits, in terms of the core mandate for each department, you can click, thanks. You will see there's the health one, and the core responsibility for health is, of course, to provide those core services, health services, which include clinical services. Then, you can just click and they will all, in essence, this slide captures, Hannah, you can just continue clicking so that all of them are there. It summarizes what is the responsibility of each of those core departments that we've identified. And they are, of course, home affairs. They include basic education, the Department of Social Development, Correctional Services, the Department of Health, and the South African Police Service. Next slide. So what this toolkit seeks to do is to assist committees to strengthen oversight, to improve budget scrutiny, to assess the implementation and service delivery, to promote accountability and consequence management, to focus on impact and outcomes rather than on compliance only, and apply a gender-responsive and human rights-based approach to sexual and reproductive health rights. And how we chose to do this, next slide, is that we chose to align the budget toolkit with Parliament's budget oversight cycle. So you will know that it starts off with the planning phase when parliamentary committees comes to Parliament and they submit their strategic plans and their annual performance plans. And so what this toolkit then seeks to do is once you have that process kicks in, you know what specific questions to ask for each of the departments. Then you have your budget scrutiny phase, when the budgets are tabled, and the toolkit will then also assist, are we really spending the money where we are supposed to? And of course, there's the implementation phase. That is often, of course, when you have your oversight meetings, etc., but also you have oversight visits in the provinces. This will also assist committees with asking very targeted questions with respect to implementation of sexual reproductive health and rights for a very specific parliamentary committees. And the final one is the evaluation and the monitoring stage. It is often when your annual report comes in, when you Auditor General briefings in the department, in the committee, etc. So the toolkit is essentially aligned to those phases in the oversight budget cycle, the budget oversight cycle. Sorry, next slide. The key questions when it comes to the first phase, which is planning and formulation, as I said, when your planning comes, you need to ask key questions such as whether these priorities are captured in the plans and the APPs, and whether especially vulnerable groups are adequately prioritized in the plans, amongst others. Those are some of the core questions. And whether they are aligned, for example, with your State of your Nation address, your National Development Plan, and also South Africa's our constitutional commitments, as well as some of our international commitments. The toolkit also makes reference to South Africa's international and regional commitments when it comes to sexual and reproductive health and rights. And it also asks specific questions around some of those commitments, but linked to the budget oversight cycle. Next slide. So those are the key questions. So when it comes to the budget scrutiny, the sets of questions, the essential question really is, are we allocating sufficient and equitable resources? And there's a whole set. This is just a sample of some of the questions, but if you look at the toolkit, you will see that it's very detailed and very specific for relevant committees. And for example, if you look at the Correctional Services Toolkit, when it comes to planning and budget scrutiny, it will ask questions around access to reproductive health and rights services, sexual health, protection against gender-based violence of inmates. But when you look at the social development toolkit, for example, it will speak specifically about the socially vulnerable groups that the department is meant to provide a safety net for, but also services such as older persons and gender diverse persons and LGBTQI plus persons, and of course children. So it's very specific to what each department's mandate is. The toolkit sets out South Africa's national commitments, the constitutional commitments around sexual reproductive health and rights, and then it also speaks about, in terms of international commitments, what are we meant to do, and then it moves into, for this committee, these are the things that you need to focus on when it comes to sexual and reproductive health and rights. Next slide, please. When it comes to the implementation phase or the service delivery phase, the key question really is, how are these plans translated into services and results? And it also asks specific questions that will assist members with asking the right questions and targeted questions around implementation during oversight or during briefings from stakeholders. Next, please. And then the final phase, sorry, that's a duplication. Okay, so I've skipped the last one, which is the monitoring and the budgeting one. My apologies. But yeah, it shouldn't be implementation, it should be monitoring and evaluation. And the question is whether we are achieving the measurable outcomes and accountability. And it asks specific questions around, now that these are if the particular groups or particular focus areas are included in the plans, is it taken through in terms of the budget? Is the adequate and money allocated for those then? And then in terms of service delivery, how do we provide oversight on that? And when it comes to this phase, the fourth phase, we ask questions around what are the outcomes and whether particular target groups were reached and to what extent. Next slide. So this is just a summary of the different focus areas for each of the core departments. That is for the health mandate, as you can see. And the health toolkit was developed to help members assess whether health services and accessible, equitable, and adequately, I'm sorry, I can't read from here. I should have brought the wrong set of glasses. I'm just going to grab this. My apologies. I overestimated my vision. Yeah. So then let's move to the next one, Hannah. So there you will see what is the social development mandate, and it speaks specifically to what social development does, like shelters, prevention of child marriages. That's a core area to focus on, and I think that also came out this morning in this morning discussion, and supporting vulnerable groups and families, and of course child protection. And it also asks very specific questions around how does the social development in terms of your budget oversight cycle, how does that speak to sexual and reproductive health and rights? Next one. Then there's the SAPS mandate, and it also speaks specifically around what SAPS focuses on when it comes to sexual and reproductive health and rights. It's about, protecting persons from especially GBVF and investigation, etc. And then it asks specific questions such as, case, the number of cases, percentages that were investigated, etc., very specific to the SAPS mandate. Next one. And essentially, this is what Home Affairs deals with, and I think the question was asked this morning that we omitted Home Affairs and the correctional services. But as you can see, there is a focus on migrants, and there is a focus on detention facilities in the toolkit. And also Home Affairs' role with respect to anti-trafficking, the protection of migrants and vulnerable populations. And of course, we know that enabling documentation is core for accessing services. And so Home Affairs plays a key role there as well. And when it comes to prevention of child marriages, for example, of course, Home Affairs is responsible for verifying the age of persons in the country. So they have a core role to play, and the toolkit sets out to ask very specific questions with respect to what Home Affairs mandate is. The next one. That's the basic education, which is mostly empowerment, education, and prevention. Very specific in a school environment, including school safety and learner support systems. So the toolkit speaks specifically to that mandate. And I think the last one would be the correctional services mandate. Of course, as we said this morning, when people do not lose their constitutional rights when they are incarcerated. And so correctional services has a key role to play. As also in terms of protection against sexual and gender-based violence in prisons. It is a high-risk space, and so there's also very particular sets of functions and responsibilities that's clearly outlined for the correctional services mandate. Next slide, please, Hannah. In essence, the toolkits recognize that while sexual and reproductive health and rights is one national priority, each committee or each sector has a unique oversight responsibility. And together the key toolkits provide a common oversight framework while also allowing committees to ask sector-specific questions that reflect their unique mandates. That is in essence, thank you colleagues, what the toolkit seeks to do. I hope all of you have managed to get copies of your toolkits if you want to ask specific questions. Thank you so much, Chair.
Thank you, Ms. Paulser. So I think it's obvious that it's a structured approach to oversight in this area of SRHR. And based on the budget oversight cycle with specific guidance to those sector committees for oversight questions and so on. And I think so the utility is obvious. It's the utilization that would then be our biggest challenge, that this then finds expression in the work that we do as support staff to those committees, but also how members then utilize this as a guide or a toolkit in terms of utilizing the oversight mechanisms that members use both at committee level but also in plenary, posing questions to ministers and so on. So thank you very much, Berenice. We're going to move directly now to our next presenter, who is a colleague from the Sexual and Reproductive Justice Coalition. Just a quick introduction of the coalition itself. For those who may not be aware, it's a feminist black woman-led cross-movement building coalition. The coalition comprises over 180 individual and organizational members with a core approach to build collective power, facilitate linkages, mobilize resources, and strengthen capacities using an intersectional framework of reproductive justice to affirm that health and socioeconomic realities aren't mutually exclusive. We have the privilege of hearing from Ms. Lesego Twale, from the they, them pronouns program coordinator at the SRJC. Lesego is a communications, advocacy, and campaign specialist with more than 10 years of experience working across LGBTQIA+ sex workers, HIV, SRHR, and gender justice rights. And her work together with her colleagues span strategic communications, advocacy program management, campaign development, and stakeholder engagement. at national, regional, and global level. And currently, they work as managing coordinator for SRJC. Over to you, Leseg.
Thank you so much for that introduction, and good evening, everyone. I don't know, all protocols observed, not my style, but evenings. And thank you so much for the invitation from Hannah and the department, and for allowing the voice of civil society to be here in this space today and to witness the launch of these toolkits. I think it's a fitting time, and I think even though I come at a graveyard section where everybody's sleepy and full and the room is half empty, but I'm glad that I come after the launch of these toolkits, which I think they're very important in the work that we do, because in our work in SRHR, and our works is at giving you a brief background on SRJC. We work in the intersectional of gender justice, where our work is more focused on rights. So we want to interact with Department of Correctional Service, of Justice, of Health, and everybody encompassed. So, and because we work with vulnerable groups, and our focus areas is LGBT, sex work, youth and young women, adolescents, as well as key populations. So this, I think, for us comes at a very prominent time in our work and in our advocacy, and we hope to see these toolkits being disseminated and being shared widely, but also being implemented, because we know that even though our constitution is one of the best in the country, but the implementation always lacks. So thank you for that, Ms. Benis, for sharing those toolkits with us. Most of my presentation, you can go to the next slide, has already, a lot of the things that I was going to cover has already been covered, and I think that's the unfortunate part of being the last to present. But I think just to touch on that and just to add an extra voice to the story of Lerato, to add a story of Jabulani, who is now Jabulile, a young trans person who is now finding themselves as a different person in a world that is very discriminative, that's full of stigma, that's full of judgment, and in a school setting that is judgmental, teachers that are not well-versed around issues around gender, identity, sexual orientation, and all these aspects. And then now just imagine Jabulile trying to navigate sexual reproductive justice, gender affirming care, and all these other aspects that would make her life more meaningful and healthy and happy to live, like any other person that would require those kind of things. So I think I just wanted to add that aspect, because yes, a story around Lerato is important, but there are key population and young people who are marginalized, who also have struggle with access to SRHR. And these are the unseen young people, unseen communities, because they're not in the forefront, and their stories are normally being masked or ignored or erased. And we are seeing this with the rise of the anti-rights movement in our continent. And it's something that we cannot ignore. It's something that we need to speak boldly about. It's something that our parliament needs to speak boldly about, because we know they don't just infiltrate churches, civil society, and other movements. They are infiltrating our MPs and parliamentarians, and they're using parliaments to push their agenda. So as we gear up for a conference that's heading onto our shores next year in May, we really need to stand firm around protecting the rights of this country, but also the declarations that we sign on in international spaces. I just wanted to put that out there, because as in my presentation, it says that South Africa has one of the beautiful laws, but they exist in paper, but in reality, they do not exist, and they're not being implemented. So with the scope that I was given to talk about SRHR and youth
and marginalized communities, including LGBT and sex workers, I think for us, what we see, especially when we do our work in SRHR, we see a lot of, and especially when we work with young people who are based or go to school in rural areas and townships and communities that are underprivileged and who don't have access to private healthcare and are dependent on public healthcare. We see that there's a lot of unmet need for contraceptives. A lot of the kids, when they go to seek contraceptives or services around SRHR, there isn't enough, there's stock outs. It's either they are being judged, or as the previous speaker has spoken, why are you seeking these services? Are you not too young to be doing this? All these other things and judgments that come with being a young person and being told how to exercise your bodily autonomy. We see and adolescent pregnancy is still a huge issue in our country, and it's one that we shouldn't be ignoring, and I think one that the Department of Justice should be taking with a more stern hand, because we can't have young people as young as 10 being pregnant, because that is not consensual sex. It's statutory rape, so it should be seen as that, and people need to start being prosecuted. So we can't still have in 2024 and 2025 have stats of over 100,000 kids still being pregnant at a young age. That is unacceptable for a country that has laws. We see a lot of inequality, especially around HIV, because of this issue of adolescent pregnancy, which we know because if you are pregnant, it means you are exercising unprotected sex and all these other issues. Your risk of STIs and HIV becomes higher. So inequality also there happens where we see a lot of young women being affected by HIV. And because they can't negotiate condom use, they can't negotiate choice and bodily autonomy, they are dating people who are older than them at some point, or are engaged in sex with people who are older than them. And this then cause a lot of inequality, where we see a lot of young kids, especially young girls, and young LGBT, young gay boys, young trans women being affected by HIV the most. And it started at very early stage, which then means that our goal to reaching the end of AIDS by 2030, it's lacking behind, because if we are still having these issues, then we're not going to reach our targets. Another issue that I want to bring on the table, and the gap that we see, it's gender affirming care, right? Because we know there are transgender kids that are existing in our communities, and a lot of them, unfortunately, in our country, as much as we have organizations such as Gender Dynamics, Triangle Project, doing amazing work around advocating and sharing information with us, healthcare providers and the justice system, to make sure that people are recognized and for their how they identify the gender identities and the sexual orientation, but we still have a lack of gender affirming care in our health systems, where if a child comes out as trans at a very young age, they need puberty blockers. Those things are not provided. They need surgeries that would affirm how they feel inside. Those things are not provided, and the waiting list in our hospitals is very, very, very long. And in Cape Town, one of the only hospitals that provides gender affirming care, it's Groote with a long waiting list, and this is a waiting list that includes adults already who have transitioned. Now you're adding young people in this aspect, then you're prolonging their suffering in finding and affirming themselves in their gender identities, which is a problem that could escalate and snowball into a lot of things, and hence we see a lot of suicide amongst trans young people and things like that. To move on and around some of the pillars that I have identified around these issues that I've just spoken about, it's one around sexual health. Obviously,
in South Africa, HIV, we have made some progress in regards to making sure that there is HIV prevention healthcare. We have ARVs. We have a very good working system in terms of HIV provision in the country, but also it is not reaching the marginalized communities. It is not reaching the rural kid. It is not reaching the underprivileged kids. So what we need for these groups that I've identified, obviously we need an age-appropriate sexual education in schools so that kids from a very young age learn about sexual rights, sexual health, and what they need to keep themselves safe. Access to free condoms and PrEP for you in youth-friendly hospitals. Somebody or clinics. A colleague of mine previously spoke about, or maybe it was a commenter from the audience, about having the need to have youth-friendly clinics. I think it's important because we have nurses that are dealing with a lot, healthcare providers that are dealing with a lot, and when they come and deal with young people, they see them as scapegoats, and they are the ones that are getting affected the most with stigma, discrimination, or being, called out, or all these other things. So if we have youth-friendly clinics with young people that understand the issues that the young people are coming with, would really be helpful. We need healthcare workers that are trained in these toolkits that have been shown in issues around SRHR, in issues around to not discriminate or judge, issues around stigma and its impact on people's lives. So a holistic approach into how we approach sexual health. Also access to contraceptive, mental care, maternal care, safe abortion, and fertility support. So that is also needed for sexual health of young people and marginalized group. Around reproductive health, I think, as somebody has said, it's been 30 years of abortion being decriminalized in this country, which is a long time coming, but we are still seeing a lot of young people be reluctant to access abortion services, and this is mainly because there's stigma and discrimination around it, but also we have reluctant healthcare providers that are reluctant to assist with providing abortion services. So we need to make sure that clinics must follow the law and provide safe abortions to everybody. Youth and community leaders need correct information on safe abortion, and more funding for clinics to offer abortion, and less in private, because we see a lot of private abortion service providers that are sometimes illegal, but they are easily accessible. So we need more funding put into the public sector to make sure that young people can access safe abortion and safe reproductive health. Around sexual rights, I think this speaks a lot around the LGBT community and gender diverse groups. Even though we have these beautiful laws in our country, but there is still a lot of stigma. I mean, in this province alone, just 3 weeks ago, there was a 17-year-old transgender young person who was killed in Paarl by her peers who are also in the age of 15, 16, 17. So you can just imagine the stigma it's not just perpetrated by older people, it's also perpetrated by young people and people who are their peers. And these are the issues because education is not reaching everyone at the level where it needs to be reaching them. So we need stronger protection on LGBT, safe and respectful healthcare services, but also public campaigns that challenge and hate and discrimination. And I think these could be championed through the government because, yes, civil society is doing what they can to make sure that these issues are spoken about and they reach the communities they need to reach. But with lack of funding and currently with the funding cuts, it's very difficult to reach everybody. But through mainstream television, through SABC, through radio station, we can reach a majority of communities. And I feel like that should be something that the government champions to avoid young people becoming criminals at a young age because of hate, discrimination, and lack of information about their peers. And when it comes to reproductive rights, we still have, as I mentioned earlier, too many young adolescent girls and young women in South Africa falling pregnant at a young age. And these are due to limited contraceptives, even though we have so many contraceptives that are available and choices available to us and to young people. There is still a barrier to access those things. Harmful social norms and exploitation of young girls. It's also a very big thing, which I think the Department of Justice should be tackling head on. So what is needed in this regard, I think we need universal access to free and differentiated contraceptives for young people, and to listen to them when they say, this contraceptive doesn't sit well with me, maybe I would like to change, and not force it. Because sometimes in healthcare services, maybe you start a young girl on a 3-month injection and they gain weight, and then they go to a doctor, back to the clinic, and that, I'm gaining weight, I don't think this is right for me. They like, either you take it or not. They're not giving them another option to say, okay, there's a ring, there's this, there's that. So I think having those differentiated contraceptives options and prevention tool is very important, so that kids and young people can have the choice to make about their bodies. Because a lot of young kids do not take contraceptives because there's this stigma around your face, it's going to affect your hormones, it's going to affect your weight. But if they try different ones, maybe they might find one that is aligned with how their body works. So that is very important. Another one, it's obviously a community-wide education and campaigns around choice, consent, and power, and also focusing on gender-based violence, because I think a lot of these issues are related to gender-based violence. As I said earlier, that having a 10-year-old being pregnant is not consensual, it is abuse, and it is a form of gender-based violence. So those kind of things need to be taken seriously. Accountability needs to be one of the things that are really looked at, and system needs to put survivors first, and young girls should not be blamed for the circumstances they find themselves in, but instead they need to find the perpetrators of these abuse and be put behind bars and their names published everywhere, so that people know that they are perverts. I think what would create an enabling environment for this group of people would be to have an oversight. I think government, civil society, everyone, it is our duty to have an oversight, to make sure that clinics and providers that are meant to provide services are actually providing these services, and not just assume they are happening because there's a clinic in the corner of Hope, and wherever there's a clinic, they say they're providing it. We should follow up. Who is the nurse responsible for this? How many nurses are providing this? And how often are they at work? So that we know that these services are there. We need more funding. Money needs to be put in specialized services to reach marginalized groups, LGBTI people. And yes, we know in our civil society sector, we had a big reliance on foreign funding, which had specialized clinics that we ran that were running well. But with the funding cuts and with the USA funding cut, we saw how that could easily erase all the work that has been done over the years. So we really need government being the one providing the funding, which is funding that is localized, and that is funding that is secure, and we know that this funding is not going to be just pulled under our feet at any time, and it's something that is consistent, because that's what we need. Otherwise, the gains that we have will fade away, and then we'll find ourselves in the same place. Integration, mental health, social support, and SRHR go hand in hand. We can't talk about SRHR and not talk about the mental health of young people, or their social and economical backgrounds, and where they live, where the situations they find themselves in. We need to put that in all it should be a package when we do our work of integration. And the justice system, we need to see a sensitized law enforcement, policymakers, parliamentarians, and to safeguard our rights from anti-rights movement. And I'm happy to see that the guides that were launched today involve or include correctional service, police, and all these other stakeholders, which means that integration and thinking holistically about how we provide support is being thought through, which I think it's a great step towards a more meaningful way of engaging around SRHR. And what does inclusive look like or should look like for SRHR? I think we should make services more youth-friendly and LGBTI-friendly. We should build LGBT competency around healthcare providers, police, justice, even our communities, because this is where these young people live, and they should be able to feel safe around their parents, around their communities, around their faith leaders, and around their peers. And also address power and violence, which is very much linked to sexual reproductive health and justice and GBV. We are happy that the government and the president has acknowledged GBV as a state of emergency. And this is something that needs to be prioritized because it is one of the things that it's influencing a lot of these issues that we find ourselves in. That's where I will end it, but I want to say that it is very important for us to work together as government and civil society and just individuals who are activists to make sure that sexual reproductive justice is realized. Thank you.
Thank you so much. Lesego, can I ask you to join us here at the table? Thank you so much. So another insightful presentation from Lesego, and they reminded us that even within key populations there are stratifications, and which would require then bespoke client-specific healthcare and specialized services, amongst many other things that they raised. The importance of education, the whole area of GBV, and the criminality aspects of in that whole context of GBV, as well as the prevention of secondary victimization. So thank you so much for that. Colleagues, shall we then open the floor for input, questions, comments, suggestions? I have one hand for now, and the honourable member, and Hannah, thanks. Okay, please go ahead, ma'am.
Good afternoon, everyone. I'm Nondumiso Tumagute from the research unit. I think I've held my questions since this morning because I wanted to hear the presentations that came after lunch first. And Ms. Martha, I saw she just left, but my question also links to her. My question mainly links to the stigmatization and the accessibility to medication. From this morning, I realized we've been focusing on the public sector and then forgetting the private sector. We're forgetting, I wanted to ask, what is it that the civil society is doing to hold the private sector accountable, for instance, for sexual reproductive health access to medication? For instance, with the private sector, if a medication is not profitable to them, they're not providing that to the public, then it pushes it to the public sector, and that pushes much pressure on the public sector services, whereas the people that can afford to pay for that medication are not being afforded that opportunity to pay for it. For instance, in South Africa, I think a few years back, we had a stock out of penicillin. We ran out of penicillin. It was only being offered in the public sector because the private sector was like, we're not willing to pay for this penicillin. And it also with the HIV AIDS management with maternity health care. With the private sector, if you listen to people who've been pregnant before, who are HIV positive, and go through the public sector the private sector route, they get stigmatized so much because HIV is looked as a low cost or a low economy disease that the private sector should not be looking into. So my question was just linking to that, is what is it that the civil society is doing towards the private sector, not only focusing on the public sector, because also in the private sector there's that stigmatization, and it also limits the access to SRHR resources. Thanks.
Thank you, Dumakude. Any other inputs, colleagues? Hannah has left the room. She had a hand up. Go ahead, ma'am.
Thank you. On the development of the toolkit, maybe I think she said it that there's still more which are going to come, which is really needed in different sectors. So I do encourage that, and we'll make a follow-up to see how far they'll be with other toolkit which are really needed in the community. And thank you for that. It gives us even field workers you are paving our way. You are making our work easy with this toolkit. I just look at it for a few minutes and I could see how helpful it will be. And from tomorrow, I'll start using some of it. Thank you. And when it comes to the presentation of on the LGBT, being a field worker, I see and I touch the discrimination which is happening in that community. So they are double discriminated. So if, for example, there's discrimination in the black community, so being a black person and from the LGBTIQ community, you are more. So if you are a migrant, being a LGBT I community, it's more. So how can we educate, and how far is this education? Because even us who are field worker, when we advocate for rights of the LGBTIQ community, we are also discriminated. Like from the migrant community, we see that as evil. So now you too, you are discriminated because you are advocating for that. There was a couple, they were looking for a place to stay. So again, I'll go back for the housing. When they will develop the toolkit, the housing, water and sanitation needs also to be there. So when they were looking for the house, there were places, different places, where there is a room available. But when they introduce themselves as we are a couple, immediately the room is not available. So it put them in a very difficult situation. They could afford, but because of being from the, so how can we take this to the community and not being judged or seen as promoting something which is not African, according to. Yeah, thank you. That's my.
Thank you, Hannah.
Thank you so much. I wanted to direct my question to you, Lesego, or anybody else who feels they can add to the discussion, but I was quite taken by that example you gave of the murder in Paarl recently of a trans youth. And I think part of it is because I often assume that younger people tend to have more progressive ideas of gender and sexuality. And of course, that is an assumption and clearly an inaccurate one. But it got me wondering then whether comprehensive sexuality education or any other education youth receive on sexuality and gender contains much information regarding transgender identities, regarding gender diversity, how up-to-date that curricula actually is nowadays. I'm not sure if we have anyone from basic education here, but I would love to hear more about what is actually covered in that regard. And then secondly, thinking about the health setting, the healthcare setting, and what kind of initiatives actually work when it comes to trying to tackle stigma against gender and sexual diverse people. I don't know if you have any examples of work that you've done, work that you've encountered, which has actually managed to make a difference, given, you know, as somebody who actually comes to these settings trying to promote more acceptance, you can actually then become a recipient of that stigma and discrimination. It is a very touchy and very contentious field to be in, so I am curious to know what you've encountered there. Thank you.
Thanks, Hannah. Are there any other inputs? Yes. Any other hands? And Dr. LaRue, thanks.
I hope you could hear me. My name is Annie, and I'm a researcher with the PCN Police. And you'll excuse me if I'm a bit confused here. My thoughts aren't as developed on this as I would like, but I would very much like to hear your thoughts on the interplay between criminalization and fair access to services. So Lesejo's point about a 10-year-old giving birth actually made me think of this again. The statutory rape inquiry that Hannah spoke about earlier was extensively discussed in the PCN Police, and particularly on where the responsibility lies for reporting such instances, especially in cases where small children, like 10 years old, give birth. And then given the earlier discussion on people turning to backyard abortion clinics because it's a transactional environment that protects your privacy, I can't help but worry about potential unintended consequences of this playing out in other instances as well. You know, going to a private backyard clinic for help where a 10-year-old was raped or whatever. So in the committee meeting, it came out that in these cases, more often than not, the offenders are protected because they are part of the community, and people don't want to give up their names. So I'm just interested in how does one go about addressing something like this? This is a very complex interplay of criminalization and access to service, but also protecting children, and it's difficult to weigh it all up. Like, how do you make sense of that? Thank you.
Thanks, Dr. LaRue.
Thank you. My question was to Lesejo as well around the context of gender-affirming care. It is obviously a very contentious field, especially in children, and there's been quite a shift in the thinking around this and the evidence that has come out. The strongest, the most robust systematic review that has been done hasn't shown any evidence of clear benefit for gender-affirming care, especially in minors. There are countries in Europe that have blocked, puberty blockers, cross-sex hormones for minors, and and quite recently, even the United States, the American Society of Plastic Surgeons have said that no surgery should happen before 19 years. So it is a little bit worrying for me to say here, you say that those things should be available to children in South Africa, especially in the public sector. And so I just want to understand why you guys are saying that. I think that the evidence at the moment is still, if we want to be evidence-based, the evidence is quite, at the moment, doesn't, according to the best systematic review that we have, and the only real systematic review I have, says that the evidence isn't clear on that specific factor. So that's not taking away from the fact that there is significant stigma associated with transgender, and that we need to protect these young people and older transgender people as well. But I think I just wanted to raise that issue because I think it is important that in this context we are accurate with our information and our evidence. Thank you.
Thanks. Should we take some responses? I'm going to start with you, Lesego, and then Berenice. Hannah, if you have anything to add.
Okay, thank you so much. Many things to respond to. But let me start with you because you just recently spoke, but just to correct, yes, there is evidence, but that has shown, and there are countries that are rolling back on puberty blockers that have already implemented those puberty blockers for teenagers or young people, adolescents that are hitting adolescence and puberty stages. And in South Africa, it hasn't been a thing that is being provided only for people probably maybe in private settings that can have that access. When I speak about children and in terms of like puberty blockers, when puberty blockers, I'm talking about adolescents, who are reaching puberty and are between the ages of 12 to those ages, who would identify either as a trans man or trans woman. And when it comes to surgeries, obviously surgeries is something that only happens when you are, and when we talk about young people, we also talk about people between the ages of 18 to 24. So these are also young people that would be eligible if they would choose to do a surgical or go through the surgical route of transitioning, and those are that aspect. But in terms of kids under the age of 18, the surgical route is obviously not a thing, but for puberty, in terms of hormonal care, it is something that is provided in other countries, but not in the country. And it's something that I think organizations such as Gender Dynamics are advocating for, because we are seeing more and more young people who are coming out and are suffering a lot with mental health because of their gender identities. So that, to correct that, but obviously we also know that a lot of these roll back on these rights, and it's because of the anti-rights movement. We see it in the US, how it has happened, where people have just would go, even those that have already transitioned, whether young or old, would go and would try and update their documents, and it will come back with their dead name or dead gender and things like that. And that is an aggression on the rights of gender diverse people. So it could be that, yes, it's part research, but it's also part the fact that there is an infiltration of the anti-rights movement that's trying to roll back on the gains of the work that has been done by activists. But obviously in our country, because we have a deadlock on medical care, and trans people find themselves at the very, very end of that healthcare. So we are still about to cross that bridge when we get there. And in terms of but obviously organizations such as Gender Dynamics, there's organizations such as Matimba that works with young people directly, Eranti, they would know more about these issues, and I think engaging with them, and they have engaged with doctors who do provide these services. And in terms of dealing with Hannah, you spoke about sexual education, comprehensive sexual education in schools, and how updated it is. I mean, it is, the sexual education is supposed to be in schools. It's supposed to be given in schools, but we know in terms of rollout for anything else, and especially in township schools and rural schools, you still have in rural areas very traditional ideologies. You still, people, we saw even with the marriage rights in South Africa, where in home affairs, when gay people would want to go and get married, and you still had marriage officers who would say, this is against my culture and I'm not going to marry you, even though they are a marriage officer. And obviously that law has now been changed to say you can't turn away people because of your religious beliefs. But we know that a lot of these rights are being blocked by either people's religious belief, moral beliefs, and all these other things. And you might find that the sexuality education, it is updated, but it is how it is then rolled out in schools. Are schools prioritizing rolling out this education to kids in the townships, in the rural areas? And if you see where these crimes are happening, where young people are killing other young people who are queer, it's in Kailicha, there's about probably 5 cases of young people who have been violent towards LGBT people. So you see that the trend is either it's in township or it's in rural areas and things like that, and you don't find it in the southern suburbs. And it's because of the educational system and how then information then gets to reach certain areas, and it's about the privilege point and who gets information and who doesn't. So I think civil society is doing what they can to do the work, but I think there isn't enough civil society organization to be able to reach everyone, and there isn't enough funding to reach each and every person in this country, let alone in the entire Africa or SADC, for instance, if we're just going to keep it very close to home. So the issue here, it's about how does then government help civil society to reach those blind spots that are not reached, because young people shouldn't be the one perpetrating because of information these days. There's TikToks, there's everything, there's information overload. So you shouldn't be discriminating against another, but unfortunately we still see it happen. So I think it's just on how and where information is available and how people are receiving it, that is creating these issues that we are seeing. And we are finding it worrying that more and more young people are the ones who are perpetrating these violence acts. And it is a difficult one when you have to deal with secondary stigma, because, like I said, moral, religious, ideology, and especially if you're dealing with migrant communities in their country, in countries that people come from, it's criminalized already, and in South Africa, yes, we have the privilege of having these rights, but a lot of people come from contexts where these issues are criminalized, are named an African and all these other things, and they are also scared for their own self to say. People back home will think that now I'm here in South Africa, I'm promoting, homosexuality. I've been taken over by, the South African evil spirit, as they call it. So it is a difficult thing where people, like somebody in the audience said, people bring their own cultures and their ideologies when they move. It's about how do you. It's not about how to change a person to divert from their culture, but it's about when you're in Rome, you do what the Romans do, So it's about how do you then integrate societies, migrant societies, into the South African society to say this is how things are done. But if even in our own society, we still have people who are not yet at par with the law and how people should be treated, it's going to be very difficult now to try and preach to somebody who's your neighbor to say this is what you need to be doing in this country when our fellow people are also not doing it. And healthcare workers, yeah. I think with healthcare workers initiatives, I think it's all about sensitization training. I think one example that we had when I used to work with the sex workers, we had an issue of a lot of sex workers being arrested under bylaws and loitering and things like that by the police. And we realized that, and a lot of police, they don't know that you can't just arrest a person by standing on the corner or by profiling them as a sex worker. You need to catch them in the act. But they still arrested people who they assumed they were sex workers. They were using condoms as evidence to say, why do you have 10 condoms in your bag? It means you're a sex worker, and things like that. And I think what really helped, the intervention that helped, was there was a project that we did, and it was unfortunately funded by COC Netherlands, and it was around positive policing. And it worked with not just police officers, but police commissioners and the high-end police at the top to be able to talk to them around laws, around arresting sex workers and how even though sex work is still criminalized in South Africa, but you can't just arrest a person by being on the corner, and the implications of constantly arresting people when sex workers want to exit the sex work sector and they have criminal records, it's difficult for them to now find employment because you have a criminal record. So through that initiative of positive policing, we then saw less and less sex workers being arrested for just being, standing on the corner and things like that. So I think sensitization trainings are important, working with healthcare workers and constant updating their knowledge around what's new, what's happening, and not doing one workshop and thinking you have changed a person's mind. Because sometimes when you have somebody who has very ingrained ideologies, they need time to kind of like change how they think, how they view other people that they view as different to them. So it's constant work with around sensitization, but I think also just making sure that we can do sensitization. We have the skills to do so. We just don't have the funding to reach everyone. But those that we have worked with and invested in, we can see the changes. So yeah, it is a long game, and there isn't a straight answer for it. I hope I covered everyone.
Yeah, I think you have, for the most part. I do want to weigh in before I hear from you, Berenice, on some of these matters. I think some time ago, a good few years ago, there was lots of advocacy and movement around the decriminalization of sex work. It has somehow gone into a lull. One doesn't hear about it anymore. And in my view, it would take a private member's bill, in fact, because I don't see any of the departments picking up on this issue. So I think there's a case to reignite that advocacy around decriminalization of sex work. And then just on the issue of education, because we talk about comprehensive education at basic education level. But isn't it also about how we educate parents, how we parent our children? Because regardless of how much education a young person receives in the basic education system, the family life and the belief systems of parents is what we pass on to our children, and we inculcate that. So you then have, how do we educate ourselves around these progressive rights that we have in our Constitution? They're there. We haven't learned how to access them, how to include them in how we live differently and how we treat each other differently. Because one of the things around belief systems, my final point, is that the approach is not to change belief systems. They're there, they exist for reasons that they exist. It is that one's belief system should not infringe on the rights of others. That is the issue. So it is about how do we make the rights in our Constitution living rights. And we haven't talked about it as a country. We just put them on paper, and everywhere we go in the world, we hold up our Constitution, and we're very proud of it. So, yeah, I want to leave there. Berenice? Yeah.
Thank you, Chairperson. So, firstly, thank you for those encouraging comments around the toolkits, and we really hope that they are useful. And as I was sitting listening to Lesego's presentation, I actually started making notes of we must review the toolkits at a later stage. And so I guess that, as we change as a society, I'm sure that the toolkits will continuously just get better. And these kinds of engagements are particularly useful because it adds a richer dimension. And so thank you for some of those comments. And we will certainly engage with Sonke when we roll out the rest of the toolkits. But as we were discussing informally during our break, there's obviously, we've identified an opportunity to work together, Parliament and Research Unit and Sonke on relevant sexual reproductive health and rights projects. And hopefully we will continue the discussions following this platform. Look, I just wanted to weigh in on the discussion around the age of the reporting mechanisms for statutory rape, etc. So I was surprised to hear that took quite a bit of time of discussion for that committee that you serve, because the Children's Act, Section 110, is very clear around the protection of children against possible neglect, abuse, sexual abuse, physical abuse, and neglect. And the Act specifically states that it's puts a legal obligation on certain professions, and it's very extensive, to report any suspicion of sexual abuse, physical abuse, or neglect. And the standard is not proof, the standard is suspicion. If there's a reasonable suspicion, you have to report it. The Act then also puts responsibility on private citizens where they suspect that a child is abused or neglected, that they should also report that. So I think Section 110 of the Children's Act of 2005 is very clear on that aspect. And the Act even goes as far as to identify the various categories. It includes traditional health practitioners and traditional leaders. It includes religious leaders. It includes teachers, therapists. It's a very extensive, even labor inspectors. It's a very exhaustive list. So I would just maybe advise you to look at that Section 110 of the Children's Act, which speaks specifically to areas of sexual abuse. And of course, where do you report it? The question was about who should it be reported to? Well, the police is one option, but also even the police in cases where there is, in terms of the Act, where sexual abuse is reported, they also have to inform the Provincial Department of Social Development within 24 hours, as well as a relevant child protection organization that's, of course, registered. So I think there are clear, sections in the Children's Act that speaks to that, and one can possibly just revisit and see, obviously review to see if it's relevant to that discussion. But I think there's a lot of guidance in the Children's Act. It's quite holistic when it comes around protecting children, and so hopefully that helps your committee, Annie. I wanted to also comment on the medicine issue, so all medical schemes, and I'm not speaking on behalf of the Council of Medical Schemes, I'm just speaking as a researcher, but there's the Medical Schemes Act and the Prescribed Minimum Benefits. And in terms of that Act, all medical schemes are supposed to fund medicines that form part of the Prescribed Minimum Benefits. And so the question to ask is, does it form part of that list? They have to fund it, so they cannot arbitrarily decide that they're not going to fund it. So you do have the right to ask questions. But for me, then, it also raised, as I was sitting here, around maybe some of the, and I don't recall that we've done this recently, maybe also look at, from an parliamentary oversight perspective, maybe one of the areas that we need to focus on is around medicines and how medical schemes and how transparent some of those decisions are from medical schemes, especially where a claim related to a specific kind of medicine is rejected. But I was also wondering, I'm not sure if there's a mechanism where they actually have to report to say, so that you can actually get a sense of, and then what types of meds are rejected. But I think more importantly, you would want to know which specific populations are most affected by those rejections. And that could be something that Parliament may be exploring. I think it's an important issue. Thank you, Chairperson.
Thank you so much, Dr. Leroux.
Thank you for the comment. I just wanted to add on to the comments about statutory rape and the issues that are around there. I think you've outlined it very well in terms of the legality around that. And I think there's and so from my context as a health practitioner, I worked in the maternity unit, and we would have young women come in I didn't have any 10-year-olds, thankfully, but we had some 13-year-olds, some 14-year-olds coming in, and there is a legal process that has to be followed, and so that would be reported to the social worker, but by law, either social worker or and therefore the Department of Social Development in the province, or a police officer, or then an organisation that deals with sexual abuse. But the challenging thing is what happens after there, right? And I think that's where, I think that was kind of what you were implying as well. What do we do next after that? And so, at the moment, there is some leeway. So consensual sex between a 14-year-old and a 14-year-old, as long as the gap, that would not be seen as criminal, but as soon as the gap in age between the young girl and the man, or young man, is more than 2 years, there might be criminal consequence. Now, sometimes that's tricky because there's a 14-year-old who loves a 17-year-old boyfriend, and that becomes quite complex. And so there would be some level of thinking about that. But it is so there are lots of difficult issues, and I think part of the problem is that too many times where there is being clear abuse or being clear manipulation or grooming or power dynamics, that sometimes gets put aside and saying, no, this was a consensual relationship, and that's the challenging aspect about it. And I think that's one aspect that one has to recognize, and I think that we do need to have better protocols and better processes, both from the police, from health, from schools, from basic education, because that's often where and it's a responsibility of teachers if a 14-year-old becomes pregnant to report it to the relevant authorities as well. So there's quite a big obligation on kind of leaders and teachers and traditional healers to actually act on this information that they're getting. I think the one other thing just to say, particularly when there is a pregnancy that results. Obviously pregnancy doesn't result from every case of underage sex, and so that's kind of probably the tip of the iceberg in some ways. But the one thing we do have then is DNA evidence, right? And so I think that's for me, in a sense, from the police perspective, I think that we need to, where there is a pregnancy, and whether that pregnancy is terminated or is brought to term, we can access DNA. And I think that's where we probably could do better, especially when there is a suspected perpetrator, or if the community don't want to say who it is, but there are strong suspicions, we then have clear DNA evidence, and we can then prosecute. And so for me, that's what we probably should be doing more systematically in some cases, instead of going, there's nothing we can do, nobody's coming forward. We could probably investigate, and we have very good evidence. So again, even the products of contraception after a termination pregnancy can then be tested for genetically, and I think that's something that we should be thinking about more in those specific cases. So I hope that's helpful.
Thank you. Thank you, Honourable Leroux. Colleagues, we are now over our time. I'm going to allow the two hands, Bernice and then Hannah, and then we need to move on. Stubby, so I hope you're ready with your summary. Thanks.
I'll be quick, I hope, Chair. There's just something that I think that we need to speak about, which for me is currently a gap when it comes around protecting children. We understand that when it comes to educators at schools, they have to be registered with SAIS, the South African Council for Educators. And the council's role is obviously to screen persons, teachers, when they, you have to be registered in order to teach at the school or ECD facility, etc. The challenge has been that schools employ service providers, especially for the extramural activities, such as your soccer coach, your swimming coach. And we do recall a couple of years ago, there were these cases around chronic sexual abuse, especially at independent schools, of service providers, because they do not have to be registered with anybody. And I do believe that is a major gap that we have currently in our legislation with respect to protecting children. And what SAIS is also meant to do, it's obviously supposed to, you have to disclose any convictions previously, disciplinary, etc., procedures. But that is not required if you are not an educator. And so those service providers enter the schools And there's not even a sense of at which schools do they provide those services. We don't have a registered database, and they are not screened. And I think that I believe as a country we are very serious about protecting our children, and that necessitates that Parliament should look at how do we ensure that these service providers, in order to deliver service at a school, that you are registered and equally screened. Thank you.
I just wanted to briefly backtrack to this issue of evidence and the systematic review that was mentioned about gender affirming care. I haven't seen it, and I'm certainly not an expert in this field at all, but I just wanted to, evidence is hugely important in guiding our decisions and policies, and rightly so. But I just wanted to highlight, some considerations, I suppose, when evaluating this evidence, especially for something like this, which is so hugely politicized. We have very powerful funders as part of this anti-rights retaliation, and this is certainly going to affect research as well. So it's important to look at who's funding it and how this might influence research in terms of who is sampled, what questions are asked. Even statistical analysis can be swayed. And also to think about how these might be averaging out effects where many people might be benefiting hugely from such services while others may not. And just because there is an ultimate finding of there being no benefit doesn't mean that people aren't benefiting. And lastly, that presumably the study is looking at multiple different contexts, and these effects may differ a lot depending on those contexts. For example, in South Africa, where gender affirming care, gender surgery and so on is so scarce and so hard to obtain, I would assume that people who are willing to stick out I think the list is 20 years for gender corrective surgery. People who are willing to seek out that care and stick it out for that long have good reasons for doing so, and so they are bound to experience some kind of benefit. That is my assumption, but I just wanted to add that to the conversation. Thank you.
Thank you so much, and thank you to our presenters for this afternoon session. I think it's fair to say that the issues are multiple and complex, and the answers will be equally complex. So the more we have these conversations and learn from each other, I think the better we are placed to advise where our role is to advise, and to keep having the conversations. Having said that, let me hand over to Sitabiso Buthelezi, who is our chief researcher, who is going to do a brief summary and key takeaways. Over to you, Sitabiso. Thanks.
Just clarity, the study that was spoke about is the Cass review that was done by Dame Hilary Cass, independent paediatrician by the British government. So there's no outside funding, and that was the basis on which cross-sex hormones and gender puberty blockers were stopped within the whole, both in the private sector and in the public sector in the UK. So that was the study that it was based on. And that was a review of, a lot of basically a systemic review of all the work that's been done on gender affirming care.
Just to clarify, when I was talking about the potential bias in the studies, I was talking about the individual studies included in the systematic review. But I will be looking this up soon when I get home. Thank you.
Okay, thank you, Chair, and good afternoon, colleagues. I know that our closing speaker will probably thank everyone, but I also want to thank our honorable members and our CSOs and all our external visitors who came here to participate. We really appreciate it. I'm just summarizing the key issues and just providing what the summary and the key takeaways are. So, and I think there was a discussion around how do we ensure that we have effective oversight and the gap between what we have as legislation vis-a-vis what we see on the ground as lived experiences of the people. We actually had a discussion also around what happens when we have these rights that we have as part of legislation, but when we look on the ground, what people are experiencing, it's quite different. And I think there were good examples that were given to us and stories and to highlight that gap between what we have as rights that are legislated vis-a-vis what we have on the ground. But also I think we then realized that having good legislation and laws does not guarantee that, in fact, these will be realized in practically. And that could direct us to that oversight that is lacking to ensure that we implement these rights. So we then discuss how then to ensure that Parliament improves, how do we close the gap or minimize the gap, what tools can we use? And it brings us to the toolkit as well, and to all these tools that we can come up with to ensure that we close the gap between what we have as legislation and what we have practically. So I think there's acknowledgement in the room that we do have a very strong and a very good policy framework, and we do have very good policies. And the key issue that is always highlighted, and I think in all the events that I attend, is how do we close that gap to ensure that implementation is much closer to what we have as part of our policy framework. And also the discussion was around how then these anti-rights groups are exploiting this gap that we're talking about, and where they have realized that there is this gap where we have these laws, but they're not really effective implementation. So there's this rise in these anti-rights groups that are trying to exploit that gap as well that we see. But also, I think also one of the presentations highlighted what that despite that there has been very good progress in coming up with these laws, there's still some room for improvement. And I think we highlighted laws around child marriages, criminalization of sex work, some integration between gender and climate management policies, consideration and gender-focused policies. So there's still some room for us to maneuver as well as part of as Parliament, and as part of our job in lawmaking as well. So there's still that room that we can do some of the things to improve. I just want to highlight then on the tools that we have at our disposal as Parliament. So that was discussed a lot. And part of the toolkit as well, we highlighted here that it's to help committees in their oversight role, but also to give CSOs an idea of our thought process as Parliament starts doing its oversight role. So this toolkit also gives some insight for CSOs to get an idea of what committees will be looking at going forward. But we do anticipate that the toolkit is part of Parliament's tool. We should be able to assist in addressing some of the issues that I've highlighted as well, the gaps that I've highlighted. I think as part of research, I get excited when I hear about data collection, production and distribution. There's a need for us to really institutionalize these engagements, especially with CSOs. I think what I've gathered here is that there's a lot of data that is produced and collected by CSOs as well. There is a challenge with gathering live data that is coming from communities, and we all have that challenge as well. I also struggle, I think, when I have meetings with senior researchers, we always speak about collecting data that is coming from it, which is very difficult and which is very expensive. But there's that gap. It's an untapped market that we really need to find a way. I think what this told me is that we need to find a way, how do we institutionalize this sharing of data, collection and production as well, and how do we find ways to make sure that we use more of that data that is coming from the ground. But that then helps us to have some form of data-driven oversight as well going forward. So I think, as I said, it's how do we institutionalize that and build those partnerships so that we are able to strengthen the tools that we have. lastly, one of the issues that was raised also by Dr. Gabriel just now is, as lawyers are taught very young that does everything need to be legislated? Can everything be solved by legislation? And some of the challenges here have to do with strengthening our education function. Making sure that we create an informed citizen, who exercises their rights, and social norms and cultural belief, with knowing very well that they don't have to infringe on other people's rights. And in some cases, that has nothing to do with legislation. It has to do with us using other tools. I think there is so much room for us to utilize other tools, such as education, to strengthen the oversight function of Parliament. But I do get a sense that not everything can be solved through legislation. We might as well try and solve this through other tools. But in a nutshell, Chair, as I'm closing, so there is a role, a very important role. I think as we have these engagements with CSOs, we realize that there is more room for us to collaborate. There's more room for us to speak to similar issues. So I think we need to find a way, how do we institutionalize that and build that into our research plans and going forward. And that stakeholder relations that we spoke about with CSOs actually needs to be strengthened. And also stronger collaboration and sharing of data so that we improve evidence going forward. On the other side, the other leg, which is also promoting education and of citizens and strengthening that leg as well so that we improve oversight. But Chair, I think that's about it on my side. Thank you so much.
Thank you, Mr. Biso, for that high-level summary. Let me, before I hand over to Dr. LaRue to do the final closing remarks, just remind colleagues that there will be the survey again that Hannah would put up before we close for today, and then also that today we're closing today's discussion. So I encourage you to link to tomorrow's online discussion, which will then be a half-day session. Over to you, Dr. LaRue.
Thank you very much. It just remains for me to say the thank yous. And firstly, thank you very much to all of those who presented, to Bernice, to Martha, to Lesego. Thank you so much for your inputs and your perspectives. Thank you also for everyone and colleagues and I they say that broadly, not just to members of Parliament, but colleagues in Parliament and members of the research teams for your inputs and your thoughts, and I think that's been very, very valuable. Thank you, Leon, for chairing and your succinct and nice direction as we've gone through the day. And Anna, also thank you so much for putting this program together. I know that you've been driving it for a while, and so we are very grateful for the work you've done and your team have done to get this day together. That's it. Thank you.
Thank you so much.
I am attempting to project the QR code for the post survey. It's not showing. Oh dear. It's not working.
You can use it with your computer.
Yeah, I might need to pass around my laptop. Okay. I don't know if...
I think you turn it around.
Yeah, you can zoom in with your cameras or something. But also just to mention, tomorrow's event will be going into more detail specifically on budgets and financial oversight. We have a presentation from the Parliamentary Budget Office, who will also be presenting the results of a report we did looking at SRHR spending in South Africa, but also looking practically at how we can improve our financial oversight as members of Parliament and civil society. And we'll also be hearing from the Budget Justice Coalition, a civil society organization, who also do this sort of gender-focused and SRH-focused budgeting analysis. So I do hope that some of you will be tuning in and to gain some more practical insight into how exactly we implement some of these lessons today. Thank you.
Thank you very much, everybody. We are adjourned.